We're gonna go ahead and call this meeting to order. This is the January Medical Cannabis Policy Advisory Board meeting. I appreciate everybody for coming. We got some good items on the agenda today, but before we get to those, we'll go through the welcome, we'll go through the minutes, a few other things, and then we'll get to our three substantive issues. So this meeting is being held virtually and is hosted by the Utah Department of Health and Human Services, Center for Medical Cannabis, based in Salt Lake City, Utah. Public notice of this meeting was provided as required under Utah's open meeting laws and was posted on the Utah Public Health website. In compliance with Utah's open meetings law, this meeting is being recorded. Recording of this meeting will be posted to the Utah Public Health website no later than 3 business days following the date of this meeting. A rough draft copy of the unapproved minutes will be posted to the Public Health website within 30 days of this meeting. Approved minutes will be posted to the Utah Public Health website within 3 business days after the board. The agenda is up to the discretion of the board chair. As a result of board meeting proceedings, agenda items may be removed, skipped over, or pushed to a meeting in the future. Just to go over again, like we do every meeting, the public comment instructions. These are the general instructions. Public comments will be limited to 2 minutes per person. If you want more time, you must request it from the chair. The chair may accept or reject requests for additional time. A public comment period is not guaranteed every meeting. The chair has the authority to create or remove public comment from the agenda or during the meeting. You can look over public comment guidelines that are posted on the Utah Public Works website. Please state your name and your affiliation when making a public comment, so it can be reflected in the meeting minutes. Only comments made on items listed on the agenda will be considered. If you have a comment about an item not listed on the agenda, please email them to MCPAB@utah.gov. For those making public comments over Zoom, the Zoom public comment chat will be disabled during Zoom meetings. And if you want to make a comment, you will need to fill out the comment registration form found on the public notice website. The chair will indicate when it is time for the public comment period and will determine when it is your turn. You will then be taken off of mute. Take 2 minutes to make your comment. Chair will then decide whether to take additional comments other than those who filled out the public comment registration form, and you will use the raise hand icon on Zoom to indicate if you would like to make a comment. For those making public comment in person, please sign in on the public comment sign-in sheet with your name and indicate what agenda item you want to make a comment on. The chair will indicate when it is time for the public comment period. The board chair will call on you when it is your turn. You will come to the public comment table. Take 2 minutes to make your comment. As a reminder, if you are in person, please do not speak when others are presenting. Our mics are very sensitive, and those attending over Zoom cannot hear when there is more than one person talking at a time. Side conversations and comments from the public during this board meeting are prohibited. And for all additional information, to make a suggestion for agenda items or to contact board members or staff, send an email to MCPAB@utah.gov. All right, with that out of the way, we will turn to approval of the December 2023 minutes. Has everybody had a chance to review the minutes from December 2023? Does anybody have any proposed changes?
No. I'd move to approve the minutes.
All right, we have a motion to approve the minutes. Do we have a second? All right, we have a second. All those in favor of approving the minutes, please say aye.
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 Any opposed? All right, looks like the motion passes unanimously. As far as administrative business, I don't know that we have anything really formal. I will mention, Trevor may have something, but I will mention that the legislative session did start today. I know that one cannabis bill has already been made public and has been numbered. It's the 280E tax credit bill. That is being run by Senator Vickers. I don't know if he's found a floor sponsor yet, but I do know that bill is live. I know that we all supported that as a board. So I encourage you to pay attention as it goes through the session. And for those, I wasn't very good at this initially, but I've gotten better at it now. You can track bills individually. Through the legislative website. It makes it a lot easier than trying to just see when they're going to come up, because they'll go in front of committees and different things. I would encourage all of you to get up there for at least maybe one committee hearing to see how see how things go. Talk to your lawmakers and things like that. There's likely more bills to come, but that's the only one that's been made public on the medical cannabis side at this point. There is also a hemp bill, but that is generally not something that we deal too much with, but you can read that as well. I believe Representative David Provo is running that bill from the House. So one thing I think to just keep in mind as we go forward over the rest of this month into February and into March, there may be times that we have to, we may have to have an impromptu meeting, right? If some legislation comes up that we think that, requires us to, to weigh in. But as the bills become available, we'll make sure they get circulated amongst the group. And if we do have to do some type of, public meeting, we'll make sure to get together for that. But, more to come there. So, did everyone have a chance to fill out the survey that Trevor had sent out?
We did get everyone.
Good. Hopefully we'll hear on what the responses are, and we will make changes accordingly. But I appreciate everybody for doing. Any other administrative business, Trevor?
I think we
Oh,
should
yes.
recognize we have a new qualified medical provider on the board. The position was vacant since October. But I'd be happy to allow Chris Morgan to introduce himself to the board.
Thank you. Sure. My name is Chris Morgan. I'm from Logan. I have a practice up there, and roughly between me and the other nurse practitioner I just hired, we see about 400 active medical cannabis patients. In addition to our regular endocrine and family medicine patients up there. So he's a size practice. I've been a QMP from the very beginning. I think my card number is 15 or something. So I've been doing this since 2020, and I've seen a lot of good things come about with access to this. It's an additional treatment option for patients.
Wonderful. Well, Chris, happy to have you. Which actually did spark something. Rich, can you give a short little update on where we stand in replacing the other vacancy on the board?
Yeah, so the additional vacancy is the mental health specialist position, and we do have someone that's been identified. It's just a matter of getting that approved internally, and we should have that done this week.
Wonderful. So we can probably expect to see them at the February meeting.
Yeah.
Good. Wonderful. I have a full board again. All right. Any other administrative business from anybody else on the board before we turn it over to DHHS and UDEF for their updates? Take that as a no. All right, we'll start with DHHS first with their updates. Rich, please.
Yeah, just by way of information, some of the bill numbers that are related that JD was mentioning earlier. The first one is Senate Bill 71, that's cannabis business tax credit amendments, sponsored by Senator Evan Vickers. That was introduced for its first reading this morning before the Senate. So seems like it's a high priority to get that through. And then also one that has a lot of amendments that are not significant, but are still very important, is that there's some definitions moving between DHHS's statute and UDAF statute, and that's happening in Senate Bill 46, Health and Human Services Amendments. That's also on the Senate reading calendar. So that's SB 46. It's a very long bill because that is, it's a housekeeping bill for the most part. And so there isn't anything controversial in there. It does move specifically the definition of advertising and targeted marketing from our statute to AG's statute. We maintain some definitions, but those are modified because it relates to QMP advertising only, of course, and targeted marketing within the authority that we have. And then that industrial hemp amendments bill, that's HB 52. Representative Daley Provo is running that one. And then the one that's not numbered that was mentioned earlier was the cannabis pharmacy modifications. That's Representative Walt Brooks, and that is still in process. Has not been made public yet. So those are 4 bills that I'm tracking. That, if you're curious, those are some of the bill numbers. Okay, just a few items. January 30th, the University of Utah Center for Medical Cannabis Research. They're holding a symposium. I think we've mentioned that in the past, but it has an agenda now, and it's from 10 a.m. to 4 p.m. Dr. Ethan Russo, who in the past has presented to the Cannabis Research Review Board virtually. He is coming in person to present at that conference, at that symposium, and some members of our staff will be attending that, and also members of the Cannabis Research Review Board, I believe. And Misty, are you attending as well?
I'm actually participating. We're at panel
Great.
groups.
Great. So great to see that University of Utah Research Center is moving forward and gathering some experts in Utah and bringing in this individual that has some expertise from outside Utah to help advance our research efforts in Utah. Also on Monday, February 5th, the Utah Academy of Family Physicians has a CME conference up in Park City, and Dr. Matt McKiff, who we've contracted with as a QMP, to present on topics related to treatment of medical conditions with medical cannabis. He is presenting on medical cannabis treatment basics. That's Monday, February 5th. If anyone is interested, it's the Utah Academy of Family Physicians that's putting that on at the Westgate Hotel in Park City. And
You know if that'll be presented via Zoom or?
I believe so. I think it will be virtual. I think part of the conference is it's also gives people an opportunity to go ski. So
So
that-
they'll all be in class.
yeah, they'll all be in class. Anyway, but we're excited. That's, I think, from 7 a.m. to 8 a.m. is when Dr. McKiff is presenting. And he's the chair of the Cannabis Research Review Board and also a QMP we contract with to do presentations. So also just a brief update about the new electronic verification system project. That is on track to go live in the spring. And that again is going to be built on the Salesforce platform. We're working closely with AST, our configuration vendor, on that, and a number of our staff are dedicating a significant amount of time supporting that project to make sure it's a success. So also just some 2023 stats, if you're curious. So as of today, we have 77,500 active medical cannabis patient card holders. And of course, we're nearing our 4-year mark in March. And in December 2023, we had quite a large jump, over 2,000 additional active medical cannabis patient card holders joined the program. And that is the highest jump we've had monthly since April of 2023. So that was a significant jump. Also, if you take a look at December 2022, we had a jump of 1,400. So this year was a much higher jump. In December, we had 2,000 comparison to December 2022 when we had 1,400.
Do you have any idea what those were from? Like, was there anything that happened during that time? I know.
I think there's just a higher number of card holders renewing.
You also have.
Just a bigger volume.
That's once the 1 year finally started to really kick in for most people from when it became effective. So what, you know what I mean? So that's what we've somewhat attributed to. I don't know if you can totally attribute to anything, but it's out of character because usually this is the time of year where you're still on the downward decline in patients coming in, and you usually see the trend. I'm sure you guys
Yeah.
see, as you go towards April 20th, you see an increase generally. So that's what we believed it to be, because it's interesting to see how many people are coming in and how few are expiring out. So I'm wondering if we think that might have something to do with it, but
You also have influx of specific. So there could.
2,000.
And the 1 year card didn't begin until July. So only half a year.
July when it began? That was when that became effective, that part of the bill. became
Well,
effective.
actually, it was May, but then July is when it started to hit, because we had some software changes that
Oh,
we were
yes.
putting into place.
Do a 1-year renewal until July?
You could, it's just that there was not, it wasn't like all at once, it was like piecemeal. People were renewing their card, and that was a 1-year renewal, but it wasn't happening in high volume until July because of how all that worked out. And then we've got 982 QMPs. There were 15 new QMPs that joined the program in December of 2023. And then we have 78 pharmacists participating in the program. And in 2023, 34,000 medical cannabis patient cards were issued to new patients. So that's a significant number there. That's our number specific to 2023. And then in 2023, 10 new active pharmacists came and joined the program. Also in 2023, there were 118 limited medical providers who completed the initial medical cannabis certifications that we've talked about. Also 55 cards issued to those under 21 whose petitions were approved by the Compassionate Use Board in 2023.
Can you tell us what percentage of that was kids and what percentage was conditions outside of the qualifying medical?
I don't have that number, but very few of them were adults.
That's what I,
Yeah, most of those were minors. Yeah. Also, our staff received 23,800 calls in 2023. So that's an average of 96 calls a day.
yep.
And majority of those we were answering in person in the moment, but some people, if they're calling over the weekend, obviously they're leaving voicemails. And then we get back to those in a timely manner. Also, the Cannabis Research Review Board, they met during the past month. And at that meeting, they discussed a patient assessment screening tool that Dr. McKiff, as chair, had circulated, and they're still working on that, getting some input from board members during this next month. They would like that to be something that's a resource to providers. Most providers have their own screening tool, but this just says, hey, this is something that the board has put together as a resource for new providers who are joining the program or ones that are interested in joining may be able to rely on that as a resource. They also approved some updates to the suggested use guidelines related to ulcerative colitis and Crohn's disease. And those updates, I believe, have been reflected in the new suggested use guidelines that are on the Cannabis Research Review Board's website. And that was based on additional research that was found, some presentation from Lauren Heath, the academic pharmacist that works with the board. That is all.
I'll now turn it over to Dr. Forsythe for any UDAF updates.
Thanks. So we'll be having the process for renewal, license renewals in February on the 7th. If anyone's interested in attending that, thinking with the staff to get an invite to there. We're also planning to make some rule changes that we discussed last time. We have a draft of our 6830 that will allow the lab to transfer excess cannabis after it's been held for its retention period at the labs to a research facility for use in research. The way that we're proposing to do this is to allow either of the labs to donate this material with consent from the producer of the material. And it would all be routed through the state lab though. So the licensed third-party laboratory would first get permission to share that material back to the university. It would be transferred to our laboratory and then would have a courier bring it up to the lab up at the university. I'll have a draft to you guys that we can share after this meeting. And then if you guys want to make any comments on it, we're not filing this rule yet, but you guys can look over it and let us know your thoughts before the next meeting or at the next meeting. That's it.
Wonderful. Thanks, Brandon. All right, let's turn our attention to our first substantive item on the agenda, item number 5, which is Pappy Medical Cannabis Processor Licenses. And I will turn the time over to Trevor for his presentation.
Thank you, Chair.
Go ahead. Wonderful.
Okay, so I will give a brief presentation, starting with some background why this issue is before us, and the current law, concerns about this issue, why it's really before the board, processor caps in other states. I should note medical cannabis states. Arguments for and against a cap on processor licenses, the concept of tying license issuances to program growth as opposed to an outright cap or no cap, and then finally some recommendation options for the board. So the background on this issue is that the program has 3 main types of licensees in the seed to sale system, as we call it: cultivation, processing, and pharmacy licenses. So cannabis cultivation and medical cannabis pharmacy licenses are subject to what you might call a soft limit. In the memo, it mentions that in statute, pharmacies are capped at 15 licenses. However, more may be issued so long as Department of Agriculture and Food consults with Health and Human Services on potential issuances of a new license after a market analysis. The same is true for cultivation licenses. There are currently 8, and there can be a maximum of 15, if I'm correct, from statute, so long as the same process takes place with consulting with DHHS after a market analysis. But processing licenses, those who actually formulate and create and package the products, do not have any type of cap stated in statute. So there have been a number of concerns, particularly from independent processors, about having no cap continue on in the market as it continues to evolve. So some of the main concerns that the board should keep in mind here, and again, these are concerns expressed by others that I'm reporting back, is that out-of-state businesses are sort of the big fear here, that they will come into Utah as the market continues to mature and take over the existing market by pushing existing processors out of business. Often these companies that come from out of state are multi-state organizations or MSOs, which have very high access to capital when compared with locally owned companies. So the fear is that those locally owned companies are existing processors. Many of them are Utah-based, will not be able to survive in a market where that type of license is subject to no cap, and that threat of out-of-state players coming in continues to be in the shadows. And finally, having one license type remain unlimited, whereas the other 2 types of licenses are capped, may cause an imbalance in supply and demand, which we'll touch on a little later. Let's go next. Oh, actually, sorry, Abby. I wanted to mention that bottom. Concerns around this issue substantially increased when the board, I believe 2 meetings ago, voted to approve a recommendation allowing for processor advertising and targeted marketing. As you can imagine, potentially out-of-state cannabis businesses that operate in multiple states might see Utah as a more lucrative market if the marketing is allowed or is going to be implemented by a lawmaker passed. So processor caps in other states, I'll point out in the memorandum, which is available online for the public and the board, there is a table at the end in the appendix going through all the other medical cannabis states and their license caps for processors, cultivators, and pharmacies, as well as giving a ratio to each, so you can see for every 1 pharmacy or 1 dispensary, there's this many processors, this many cultivators, etc. But out of the 16 medical cannabis only states, 8 have an explicit processor license cap in their statutes, and 7 don't have any cap. Utah joins 4 other states in having no cap in statute. Texas and Florida don't have explicit caps, but they are informally practiced. The RFP process for a new license is extremely rare in terms of being open. Kentucky just legalized medical cannabis this year. Their program will start in about 2 years, but it appears in the bill that was passed, there won't be any caps in that state either. Arguments for, and I'd like to mention, I reached out via email to all medical cannabis processors and was able to have a conversation with 5 of the 15 who either replied back to me or I directly reached out to. And here's some of the high level arguments from them for a cap. Number one, product supply isn't an issue in Utah. I hope we would have the 2023 survey at some point coming out soon. But what we have in the 2022 DHHS survey, which over 8,000 patients took, the majority of patients, 61%, said that they can consistently find the products they need at their pharmacies. I think it was about 25% said they could not. And the majority of folks in that survey were urban patients, not rural patients. There is more concerns around access with rural patients. A second point is that some licensees claim that there's actually an oversupply of raw cannabis to processors, and that there's a lot of oversupply that's going to produce an imbalance in the market in terms of too much supply, not enough demand. Number two, more processors could bring lower quality, inexpensive products to market. So going back to the idea of out-of-state businesses who are very profit-minded, wanting to come to Utah as a lucrative market with a cap, or excuse me, without a cap, I should say, and that they might want to sell the most inexpensively produced products in mass quantities. Existing processors may not be able to compete with that, particularly if they have higher operating costs, if they have lower volume that they're shipping. And let's go to number 3. The existing processors that Utah patients depend on could falter. It's an extension of number 2. If mass-produced products and economies of scale reign over the market in a few years, then the brands and products patients are familiar with may not be able to compete and therefore exist. So patients will have to shift to new products, and there could be a snowball effect of either more processors or processors consistently tripping over each other to get as much of the market demand as possible. And alternatively, new processors may not have sufficient plans to raise capital and maintain solvency to cover their operating expenses. You may have folks that want to come into the market and don't have an actual plan on how to acquire cannabis from a cultivator, right? If they're just a processor, they need to get it from somewhere. If they don't have plans to do that, they don't have capital to be able to invest in their operations for production. That may be, to put it frankly, a complete waste of time for them and for state regulators that would have to go through those applications, approve them, collect the licensing fee, and it would be a tremendous amount of work for everyone involved. Arguments against a processor licensing cap. Number 1, capping processor licenses considerably increases the value of existing licensees. Pharmacy and cultivation licenses, because they're capped in Utah, are very lucrative items. And while the license cannot be directly sold or transferred, I understand, that business is worth a lot more value because they have a foothold in the market. If processor licenses are capped, the existing 15 processors, it's 14 processor businesses, 15 processor locations, but those businesses, some would argue, are selfishly trying to cap in order to drastically increase their value to be able to eventually sell themselves to an out-of-state entity or to a fellow entity already in Utah. Number 2, the market should develop naturally. It's well known that Utah is committed to free market principles. It reigns in most letter and spirit of our law in Utah, and capping processor licenses means that some products and brands aren't going to come to market because they won't have a chance to even compete in this state. And number 3 is an outgrowth of that concern that more licenses means less product diversity, may mean less innovation in the market, less different and varied kinds of products for patients to try. Having more licenses may mean lower prices as well. If there's more competition among a varied amount of processors, they all may compete to lower prices for patients. And some would argue that certain businesses are going to triumph out of that, and it's up to patients to decide which businesses deserve their dollars in the Utah medical cannabis market. So an idea, instead of outright recommending a cap on licenses or to recommend no cap, is something that some states do. And I have an example, Georgia here, that the issuance of new licenses could be tied to some sort of growth in the program. Generally, that seems to be patient count. In Georgia, and although this is a retail example as opposed to a manufacturing example, Georgia may issue one additional dispensary license for every 10,000 patients that join the program after they hit 25,000. And I'm not sure how that's materialized because Georgia's program just recently got off its feet. But the board could consider something like that, and it could even ask that staff come back with some examples or talk to the board independently, talk to processors more, and see what kind of ideas could come from that. So here's those three recommendation options I just gave. The board could recommend to cap processor licenses, could continue to allow no cap, or consider exploring or even recommend a specific growth metric that would trigger the issuance of a new license via an RFP process. And with that, I'll turn it back and happy to answer any questions.
Wonderful, thanks, Trevor. Does anybody have any questions for Trevor before we open up for discussion? Okay, we can open up for discussion to the board, and then we'll go to public comment. If you're in the room and you plan to make a public comment, you need to have signed the sheet. So if you're going to plan to make a public comment, please go and sign it. Otherwise, you won't be recognized. I'll leave it to you all to start the discussion, since I'm usually the one starting. So if anybody has any opinions, I mean, I'd probably say that Matt, I'm sure, has some relevant opinions as the one representing cultivators and processors here in Utah, but I'd love to hear, the thoughts from other board members as well.
I'll go first. Everybody wants to hear what I have to say about this, but so I think, Trevor, you did an excellent job covering all of that. One thing that I think that we need to remember is how we kind of got here. Possibly, capping them wasn't just those things, but also because we are constantly coming up to questions on evolving the processor license. So if we're going to now start allowing processor delivery or processor advertisement, like you said, with marketing, just making sure that when we issued these licenses, it was a different standard. We were asking them to produce product, be quiet, hand it to a pharmacy. We were also expecting that they would be producing, and Rich knows more about this. We were thinking that in allowing a lot of processors, kind of opening that up, would be allowing a lot of different types of products. So there would be specialty products. Some would be doing really good with, one product, and one would be doing great with another, but not necessarily all creating the same. What I feel like we're doing is everybody's just kind of creating the same types of product. So that kind of negates us needing them, multiple for that reason. But as we are always looking at changing this, if we're going to be allowing delivery, if we're going to be allowing marketing, we have to remember that we didn't expect like an RFP process with these people. We didn't ask them to, fill out the kind of application that we did for a pharmacy. So, not that it really bothers me if there's a lot of processors, because that wouldn't affect me at all. I just think that we need to realize the standards that were set for processors that are now possibly changing. And that's why I support a cap, is because I feel like these people should have more say in who is applying for licensing, getting one, if we're going to be expanding what they can do.
I'm happy to add that I heard conversations from that regarding that from two processors. With a similar opinion that some say we all do the same thing. Most processors more or less manufacture the same products, and other processors, some of them say that allowing that cap to no longer, or to no longer, or excuse my tripping on my words. Allowing that no cap, may allow that innovation to breathe. But some would argue that innovation doesn't exist in the first place, and most folks are manufacturing the same products. When some reported to me, and I can't speak to the legitimacy of this, that in the initial phase of processors and that RFP process, folks purported that processors were going to do different things. Some were going to focus on specific product areas and be a master of that product class. And that's why we allowed it to be unlimited, because people could bring their ideas to market in the form of different kinds of products. Some believe everyone has centered towards vape cartridges. And whether you allow the cap to exist or not, or recommend to do so, folks will still gravitate towards what sells, which appears to be vape cartridges. I just wanted to add that some folks expressed that as well in my conversation.
And in doing the caps, we're not saying that, like, if we're not issuing more licenses, I like the way, like, kind of what Georgia did. I think looking at something like that would make sense, but then it kind of goes without saying that if we reached that next number in which they would start choosing the next license, and I came on as a potential processor with the best suppository anybody had ever seen, you would probably pick me, right? Like, because I have this unique product. That's another time I gotta say suppository. I'm keeping track. So I think that to me, I think moving towards a cap is a low risk for the program and just gives a little bit more control to the departments in which would regulate.
Maybe if I could add something else.
I want to hear from me now. I think it's as I've had the last couple of months to kind of talk through this topic with a lot of processors and other companies is, I understand that, there's concern with protecting, and a lot of the arguments I'm hearing from most people is they're worried about these big MSOs stepping into the industry, undercutting everyone, and then pushing everyone out, and then they raise prices again. We've been now coming to March to be 4 years. When you look at the current landscape of processors, essentially all of them, but like 3, got their processing licenses early on in the industry. So there has not been a lot of like new companies coming into the market. I can speak to Riverside. We partnered with several local processors at first in order to get our gummies out into market as we built our permanent facility. Wholesome had done the same kind of process until they got their facility up and running. Several others have done that too. And so, but at this point, we haven't really seen an example of someone coming out. There had been no limit. They could have come in effective day 1 and already got into this industry. So I think kind of that argument in there is it's more kind of, to me, it comes across as kind of a scare, the doom and gloom of what we're going to see. Really what I would like to see, kind of understand, a couple questions is, we've actually, if you look through the application process for processors, there's been, I can think of handfuls that have actually gotten approved for a processor license, but we've never seen them again. Do you know the exact number, Cody?
There's been 3 that there's actually 2 currently that are approved but are not licensed.
How much do they pay to get approved? Like
2,500?
Yeah.
35.
35,
So
yeah.
I guess they must have that to waste, but.
Now, is that paid again for the second year?
Yeah, every time you resubmit an application like that. So if they went to the trouble, which we did have one approved, just do that, they had to resubmit that whole application.
So there is a cost. And I think really what it comes down to is, to Trevor's point, it's supply, right? Currently it is quite limited when it comes to cultivation. There's only 8 cultivators, and of the 8 cultivators, there's only a handful of them that actually sell material to an independent processor. It's a very small number. So if someone wanted to get access to material, it makes it difficult. That's already a barrier to get in. Secondly, it's do they have the relationship with the pharmacies to get shelf space? Shelf space is very coveted right now. A lot of processors are struggling to get their products on the shelves. And so any inch they give up is probably going to come from one of these independents. And that's who's gonna be struggling. And so there has to be some sort of give and take. I mean, I kind of, my stance on this cap is I'm against a flat out cap of processor licenses. The one question I ask is, how does this benefit a Utah patient? And I can't answer that in any way other than it switches from helping patients to helping an individual company. It's away from the patient. And I think that's really what we need to be looking at is how do we help patients? And I think really what we need to be seeing is rather than an outright cap, we need to be seeing more of a robust vetting process when it comes to applicants in order to get a processor license. Whether that comes to, do they have letters of intent to purchase material? Who is that from? I always laugh because if you listen to the cultivation meetings when they apply for a license, it's the same question. If you reach out to cultivators to get material, the question is, oh yeah, reach out to them. We have discussions in place to get material. And I always look at myself and my partner, so did you get a call? And I didn't get a call, and we just kind of move on. And we've actually heard from one of these applicants on getting material. So I think if we'd be more restrictive on who's getting a license, what processes they have to go through, there can be, you can protect the patients, and that's kind of where I sit on this.
I agree with Matt. From my standpoint, I'm always going to side on what's best for the patient, the consumer. Regardless of what goes on early on, cultivation, processing stuff. Ultimately, it's the consumer, it's the patients that I'm want to protect, make sure they get the best product at a fair price. My question is there a reason why we could not cap an MSO license or create an MSO license versus non-MSO license and limit the number of MSOs that can operate, protecting those domestic entities and their growth potential here in Utah?
I can speak to that, but generally, if you put any type of residency requirement, that fails in the courts through the dormant commerce clause. It's done time and time again. They sue in every state that holds up the licensing process. Actually, I think New York just had something like that. Multiple other states have tried to have some type of residency requirement. So although very good in theory, it just in practice fails every time in the court of law. So we could, right? But we then be prepared to just have it overturned, in the courts. That's one of the problematic things is we're not able to create residency requirements. So I guess that might not be a true residency requirement, but I still imagine it's a similar type of thing. And whether it's, exactly apples to apples, I do believe a lawsuit of some sort would probably follow from your, from your MSOs. We do have multiple MSOs here in Utah too. So there's folks that probably would be interested in not limiting the ability of an MSO to go to Utah.
But having access to an MSO license with that full water, that we're able to allow a certain number of MSO licenses. Okay, so we're not restricting anything, but if one MSO leaves, then that should open it up for another MSO to come in and take that license.
Different licenses.
Yeah, I can't answer that.
I mean, it's a thought, but I think it's something worth exploring.
I think what we're looking at is then just making it more stringent, and I guess then that would be a question for Cody and Brandon, like what would that look like if we were to not necessarily cap licenses, but then to have just like a more stringent process, so we know that the people that come on board are that apply to get a processor's license, they've been vetted like they were a pharmacy. If we're gonna give them rights to deliver eventually, probably, then why are we, we hold them to a much higher standard, and what would it take for you guys to be able to expect that for them or change your process?
It's certainly possible for us to do more vetting before issuing a license to any entity. So it's not really a problem if that's the direction you guys decided you want to recommend.
Is that statutory or is that regulatory?
I think to a certain level it'd be regulatory, so we could do some rulemaking authority to, after you do another level, I think it'd probably have to go statutorily, but I think for a lot of what you guys are talking about, there's a good chance to get in.
Because there are certain requirements, obviously by statute, you have to meet to get a license. but then you all have additional requirements under your rulemaking authority. So you could potentially add
Yeah.
under that rulemaking authority, some of the things we've been talking about here.
Yep.
Rich, go ahead.
I remember when we did the original RFP for the medical cannabis pharmacy issuance, we did have some flexibility in the criteria that we created as an agency with help from Division of Purchasing. And I do remember that there was a criteria that related to connections to the local community. It doesn't say you can't be an MSO. It says, what are your connections to the local community? So naturally, people try to get points in that category in different ways. One way is that they hold in ownership, or they were a company that was Utah-based. Or if they're an MSO, they would, if I'm being their strategist, I'd say, give people in your ownership who are from Utah, who are Utah residents. Don't just have these people from out of state come in.
But residency doesn't always mean better product either, or they're
Right.
gonna be ethical in practices.
Right.
So I don't know that that solves.
And also something else to keep in mind is that over time, ownership changes. And a entity that has a license can change ownership. At one point, it was Utah-based. Then the next day, it changes ownership. It's approved by UDAF, and it becomes MSO. So, and there's no law that prevents that. There'd have to, I think, be some extenuating circumstances involved for UDAF to prevent that from happening. Anyway, those are, I think, just some things to keep in mind.
I believe Kent online had something. That's what I was told. Kent, you still got something, my friend?
I do. Thank you for looping back. I had a question if we felt like, so we had recently,
No, I don't think he is.
no,
It's red. Microphone is not.
Audio on that.
Tested it earlier, it's coming. Do
Can-
you want
can
to
you
check the
get it now?
audio? Yeah, where's the audio
Jimmy,
out?
did you say something?
Yes. Maybe they've been trying to talk this whole time. Don't want them off.
Amy,
You there, Ken?
she can hear you all just fine.
Can you hear me?
There it
Yes.
is, yeah.
Hey, excellent. Nice to join with you guys. I've been listening well. This is my first time. I was curious, recently we had taken action to cap the ownership of pharmacies. I'd be curious to know if there's some interest from the board of also considering a cap of ownership, not just the number of processors, but the makeup of the ownership of them.
I think that probably goes in line with what Chris was asking. Is that what you're looking at, Kent, is do we do like a 20 or like a 30% cap on MSO ownership within processor licenses?
It seems to be one of the big concerns is groups coming from outside the area. And I'm wondering if this is one of the ways you could kind of find a balance by using a percent. I think we'd gone with 30% for the pharmacy side. I'm not aware if there's a cap on the ownership for cultivators. I just want to know if this was going to be part of that conversation as well as we took that approach with the pharmacy. I don't know why we wouldn't do that with the producers as well.
Brandon, can you tell me of the 15 processors you have, how many are owned by this, like, as near as you can tell, the same group?
They're all different.
Yeah,
No,
so
No,
they're
there's
all-
like 3 of them that are
Dragonfly's got 2.
So they've got multiple of their own licenses, right?
right,
Yeah.
just operating in
Curaleaf
different
really has
locations.
2.
So it's not uncommon, but most of them are not independent.
We've only got
Singles.
2 that are on, a total of 4 licenses, but they're owned by 2. Are you talking about have multiple pharmacies in the state of Utah
Oh,
or sorry?
okay, sorry. So you're right.
Yes.
So Dragonfly is the other one.
Curaleaf and Drake.
Oh, yeah. 'cause they've got tractors.
Yes.
And I don't think their concern is how many licenses they have as a processor. I mean, if they want to continue to pay their fees every year, if they can process and have multiple, that doesn't impact the industry. It just gives them access to either more closer to the growing space or a better distribution location.
Yeah, that's a good point. I can see that difference being there for the difference between a pharmacy and a processor. You know, you could just make a larger processing plant, I guess, if it was not desiring to be closer to your market. So maybe it's not the same issue. I just want to make sure that that was at least a comment that was made so that I can understand maybe how that would impact things as well.
You know, personally, I talked, we talked this issue through, but this is an issue that I think was born out of, the Utah Cannabis Association, at least that's when I first heard it. And it's been roundtabled by Justin, who's gonna speak here today, and Larry, who's gonna speak here today. I've heard from, both of them in their positions. To me, I think it would make sense if you are going to put a number on it. I think that there needs to be the ability to increase that number, just like we do for the other, licenses through study. We haven't put a patient number or any other type of metric. We can talk about that at some point as to whether maybe that's a more appropriate way to do it. So it's a little more predictable, so you're not using, what you hope is objective criteria that eventually just becomes subjective criteria, because that's how it always goes, right? When we have multiple criteria to determine something, and it's not just, a bright line rule. So I think if we do place a cap, I would be in favor of one more, kind of more of a soft cap. But I also think you have questions around what happens if more cultivation gets opened up at some point? Does that cap apply to folks with a cultivation license? Can they not get a processing license? Or are we just talking about independent, processors as well? So I think there's more to it than just saying this is the cap. And then the question is, what is the number, right? Because I think that's a hard thing to do, because and I don't fault anyone for this, but I think generally when they've decided on numbers here for medical cannabis licensees in the state of Utah, it's been completely arbitrary. Pharmacies, I think is a great example. 7 was our first, number, and then it was 14, and then it was, we need a 15th one for rural. That's about the only one that I think I've seen something tied to. The 15th license was, we need more access in rural Utah. That was the specific solve, right? So I don't know how we get away from just picking an arbitrary number. There are 15 current processors. 4 of those are truly independents, right? When I say independent, I mean, they do not have a cultivation or a pharmacy license, right? So they're the true independent processors. Is that what you want to look into capping? Because that's where the MSO probably has the ability to come in the quickest and easiest. Although if an MSO has enough money, they could buy any license, right? At this point, everyone's probably for sale, depending on the price. So I'm not sure that by just capping independence, you somehow are going to prevent the MSO from coming in. Of course, they're going to have to make a much bigger, purchase. So if anything, I would be in favor of, if we are going to vote in favor of a cap, some type of soft cap that allows you to have to study in the same way that they are currently, I believe, studying both cultivation and pharmacies, on an annual, basis. If we don't cap it, I do like the idea of maybe having more some more stringent licensing requirements, so you do make sure that you are getting the right people. I do think that at some point the question is, I hate this term, but is that a slippery slope towards doing this for all licenses, right? Are we gonna be coming back as a board recommending more and more stringency on the license requirement? I feel like you get vetted pretty well, right? Before you can start your processing facility, you have to have stood up the whole thing and have it ready to turn on. You know what I mean? It's not as if, you can, just, basically just half-ass it. You know what I mean? You have to have the facility ready to start. So those are my thoughts. I think if we do have a cap, it should be a soft cap. And if we don't, I think we should look at something that might maybe provide some more robust requirements that would also then protect those who are currently licensees. But as the pharmacy representative, that's, for us, it's not as, Matt, I would listen to a little bit more, in this regard, because that's what he's speaking from. So, but I'm also, interested to hear the members of the public. So anybody else on the board have anything they'd like to put forward?
Yeah, the market analysis and I guess it doesn't really show the numbers, and I just really highlight
the strongly agree or the agree, how many patients that is, it's only 5,000 out of the 70,000 we have in the state. So I really want everyone to think about that when making a decision on capping that and saying that everyone's satisfied with the products that are available. That's not really a hugely successful market analysis, unfortunately.
How many total people responded to that survey when you guys sent it out last year?
I think it was 8,200. It was a little over
It's on
8,000.
our website. We can confirm that, but that sounds correct.
8901.
And what was the patient count at that time? Just, I mean, I agree, it's not a high percentage, so.
Yeah, I think we're at around 60,000.
15%, 14%.
But I mean,
No. Yeah.
for a survey where you're not, giving them a gift card or something for doing it.
Right, no, I think,
It's not
no
too
one
bad of a
called,
response.
no one
Right.
called, I'm just saying it's not highly successful and relying on going, oh, so many people do agree, that's not.
Yeah.
That's not a huge number, I think.
Right.
Like
No, I agree.
high adult rate.
I would tend to agree with you. Anything else from the board that I would like to hear?
The only thing I would say is, it seems like we might be missing an opportunity to learn from the folks who initially applied but then didn't follow through with the license application. I wonder if there could be like a post-application follow-up for somebody who doesn't actually obtain the next steps in order to find out what was that roadblock.
Well, we do that, so
Okay.
we try and follow up on at least a quarterly basis, and then as we get to the year end of, so, because they do have, once we give an intent to license, we're gonna have to go to approve their license, that there's 11, goes, I guess, 12 months to be up and operating. So we do follow up on them, sometimes they just go dark, we don't hear anything,
Oh, okay.
sometimes there's a lot of excuses too, and you can imagine that's something the board always asks as well when they come back again, so we do a lot of follow-up, but it just,
Okay.
sometimes we have problems getting the right facility, sometimes they just run out of money, sometimes they're oversat, some first involvement,
Okay.
things that was rare, so,
But there's no one unifying,
no.
okay.
All right, if there's nothing else from the board, I would like to open it up for public comment. Do we have anyone online? Who's raised their hand? Okay, we will turn to those in the room, and it looks like Nara is first up.
Mayor Pond, Dragonfly. So I think to kind of address the concerns around capital licenses, quite frankly, I don't think there's any reason why other than for a company to protect their own assets. Plain and simple, and I think the real concern really doesn't happen until a world of Schedule 3 happens, right? When you have the Pfizers of the world that have the ability to grow cannabis at scale, and we certainly cannot compete at scale at that. And I don't believe that the state has any jurisdiction to prevent interstate commerce to a certain extent, right? We've got certain rules around alcohol and how product gets into our state, but I think that's a real reality that most operators are concerned about. None of us in this room can compete with the Pfizer. That's a real reality when it comes down to the cost of products, right? So everything else is really just free market, right? More products, more innovation, better pricing. There's a very strong correlation to this in every single market that you look at. The states that have the most open licensing has the cheapest products, period, right? So from a patient perspective, that supports patients. So I think that's really the only concern. And I think what I echo a lot of the comments that have been said is, it doesn't matter if you're an MSO or a local operator. If you're not a good operator, you're a bad actor. And you are preventing the success of legal regulated cannabis, and our only competitor is the illicit market. And all we're doing is allowing bad operators to come in and make good operators look worse. And it makes other people lose trust and credibility in the industry when you have one bad actor, and it creates a trickle down effect. So having fiduciary responsibility as a requirement for every licensee should be table stakes. It creates a ripple effect, and every single person has been impacted by somebody else in this room because of another operator that did not have any fiduciary responsibility. Yet that is not a single conversation at any license renewal meeting at all. But that is probably the most important part of any business.
Thank you.
And I guess I'd throw it out there before we go to the next one is, that I can ask you this, and are you aware of another type of license that's being issued in the state of Utah, cannabis or otherwise, where they do put that type of fiduciary responsibility on the operator, right? Because isn't that part of the free market principle of being a good business operator? I'm not disagreeing with what we've seen, but if you're not a good business operator, presumably no one's gonna want to do business with you, and then you will eventually just go out of business, right? So that should just be incumbent upon you as a business person to want to be a good business person, and if you're not, then you go out of business. But I'm asking, are you aware of?
In a free market, that plays well. In a limited market, it allows you to continue to keep being a bad operator because no one else has a choice.
So your suggestion would be not to cap the licenses?
I don't see capping the license changes anything here. To Matt's point. Any MSO could have came in the state. Why didn't they? Because if you're an MSO, you have no business going into a state with a processing license because you have no control of your supply chain, you have no control of your retail. They're not in.
Yep, understood, appreciate that. And guys, this is probably for you, maybe Rich, you, or Cody or Brandon, because this is before I was in the industry. When they initially decided not to cap processor licenses, what was the reason behind it? I know things have changed, but what was the original reason to leave it uncapped?
I wasn't even here then.
I was either.
I can say what I remember that, but wasn't necessarily, I'm sure there was more to it, but that they were hoping to get multiple different types of products. And that because these people did not, like actually interface with patients, they weren't delivering, they were taking someone else's product that was, already tested by the state, they were producing it into something else, and they were giving it off to someone else to sell, that they felt like that was a low risk. The producers were just low risk about the, just whatever would affect patients. So, and then they wanted to open it up to make sure that people could produce specialty products. And so that's what I remember. There was probably more to it.
Yeah, I wasn't a part of those conversations when they were going on. It would have been someone at ag if there was a regulator there.
Initially, it was product.
We'll go back to public comment here, or next, I'm just sorry.
Well, I'm not gonna keep background on that. I gotta save my time for my talk.
Yell that from the chairs.
You can ask for more time.
If you guys don't mind giving me a little time, I can tell you where that uncapped processor license came from.
We'll give you your initial 2 minutes, then we'll go through the
I
form.
think it's just was there during the.
Okay, so initially, we're talking about supply versus demand. And to Matt's point, supply is actually fairly limited for independent processors. Furthermore, supply to good volume is extremely limited, especially when we talk about some of the higher demand products like solvents products. It can be extremely difficult to find good bio for that, which means in those categories, you're still seeing the price per gram extremely high, right? You're seeing $70 to $75 per half gram for certain types of products in that category. It's pretty high. When you talk about supply and demand, that's just natural. Prices go higher, the more demand there is, the less supply, prices go higher. That's bad for patients. That's tough for independents who are trying to lower their prices and be competitive. If you have multiple licenses open for some of these larger MSO groups, and then we continue to circle back to the processor delivery model, who's to say that you can't have a larger, well-capitalized MSO that acquires 4 or 5 processor licenses, puts them strategically around the state, and then starts taking away from the delivery market for somebody like Folsom or other people who tend to have a big segment of that market, right? It's very easy to see that path being executed, and I've seen some of that type of play in other states. Let's see, when we talk about not capping licenses, I don't hear anybody saying, hey, let's just open up licenses for cultivation or pharmacies, because ultimately that would also lower prices. But what we are seeing is actually a consolidation of license space. Shelf space has been limited by MSOs who acquired a significant amount of market and then don't actually fully represent the product selection that's in the market. And we see a significant amount of patients that are complaining about having access to products on the south end of the valley. There's only one pharmacy they can go to, and it's a good ways out.
If that's your feeling, would you like any more time, sir?
Yes, I'd love to get some time just to give you guys some background on why the caps are in place. So initially, for that discussion, the thought was that, originally you would have a specialized market. So certain people in other states, when you see that, the highly open market, people will specialize for vape pens or just concentrates or just solventless, right? A solventless shot. And you see that specialization kind of naturally stratified across the market. In this case, what we have is almost every processor is trying to hit every product category because the market is limited and we've seen a shrinking of the shelf space. But the original conversation was, hey, everybody's going to specialize, so we don't necessarily want to close down that processor segment. We do want to let the market develop naturally, and it has. And the natural development of the market in Utah is that everybody's trying to produce product types in all of the forms that are currently available. Now, to this point, those product offerings may specialize as we get additional product forms. But for right now, because the product forms are a little bit limited, everybody's trying to provide a product that fits one of those categories. And so that was the initial thought, is nobody was really certain how that was going to develop in Utah. And so they left the processor licenses open because if you look at other states, it could be that one strong group from out of state that was doing vape pens would come in and require a license. And just the market itself isn't really big enough to support a specialized processor right now. And I don't see that being the case for the foreseeable future. So, if we're already capping cultivation, we're capping pharmacy, why not use a metric to drive processor licenses, just like we're doing with the license. I'm not saying it's closing forever, but right now it's very hard to get me by. It's very hard to compete with somebody who was well capitalized if they decided to.
So let me ask you one question. So if we did recommend, some type of soft cap with the ability to study for more licenses. How does that feel to you?
I'm open to having whatever the metric is that the state and the board feels adequately represents the market and what the needs are for patients. Regardless of my business interests, I'm always patient first. And that is shown even in my business model. Craft producer, I focus on high quality products and lower volume. And so, if it's beneficial to the patients and it's driven off of a metric that then, if we get into a situation where, hey, we need somebody to produce these product forms and nobody that's currently existing in the market is willing to step up and do that, then yeah, we should probably issue another license. But I can tell you right now that I know of 3 or 4 processors. If a product form opened up and patients came to me, even if it was a low portion of the market, but it was a need for a specific subset of patients, we would 100% increase that product and not even hesitate to do it. So
What about the more stringent kind of licensing requirements? Do you feel like that does the same thing as a cap? Or
I
has
don't.
the potential?
I don't, what I see is larger, more well-capitalized groups already have all of the templates and forms and lawyers packages that are already done and very well polished in other states. And those guys can produce that ad nauseum for any type of license that they're providing. They've done it in multiple states, for instance, Pure Leaf's 38 or 39 states currently. They know how to play the game. They have the capital to spend all of the time that we see on it. And honestly, I can think of 4 groups who apply for licenses or who have been tentatively approved or not fully approved, where the state has spent a significant amount of time going through the procedures, going through all of the documentation, setting up hearings, doing all of that. None of those groups capitalized. And there's even existing cultivation groups that have tried to expand or change their processing requests to get bigger, and they still have capitalized. And they're growing their own product. So if they're in control of their supply and they're not capitalizing and expanding their processing, that tells me that probably have enough processors in the state, and there's no reason that we shouldn't cap those licenses.
Excellent, thank you.
I have a question. Do you think that this potential move to Schedule 3 is another reason to possibly cap licenses, or do you think that, what about you, Nara? Do you think that that's an impending?
100%.
Well, I don't think it's anything that can even be protected. Back to the interstate commerce, how do you prevent combining the getting their drugs to CVS involvements?
So what I'll tell you is, you know, and I have lobbied nationally, I've been to Washington several years to deal with some of the cannabis policy there. Schedule 3 is gonna get done. It may not be by the end of this year, but within the next 18 months, they're gonna try and push it. Biden wants to try and push it to help with his re-election piece, right? So he's got some people that are working on it pretty hot and heavy. That being said, there are other markets who have put some rough protection around their state program to try and mitigate somebody coming in, but absolutely having the processor licenses cap is one way to do that. Where just Mayor's right, like if a Pfizer or you know, Johnson & Johnson is doing some stuff down in South America, in the cannabis space, if they decide to make a move, Schedule 3 opens up, none of us will be able to compete with that. And they will run at a loss for a year or 2 years in order to capture market volume. And then they'll start trying to, they don't care about that. They have all the money that they need. And so that, you know, when you talk about product diversity, access to varied product type and quality, you know, there's always going to be a higher volume, lower quality product. There's always going to be a lower volume, higher quality product. And both of those products are important to the market for different reasons, right? And so when you talk about somebody like a Pfizer or J or somebody else like that big coming in, that really kind of wipes the product diversity conversation off of the table. And it really takes out the Utah element of the market, right? I'm very proud to be from Utah. My ownership group is all from Utah. You know, that's something that I'm proud of, right? I'm not just some out-of-state group or some, you know, investor group that bought a license and came here. I've worked with the patients from day one. I've been on the policy discussions from day one. And so I have a lot of pride in that. You know, I started with this program from this area. And I think that's an important element to really know the patients. If you know your patients, then you know the products that they need. And I think that can be lost with larger MSO groups because they are looking at metrics. They know, okay, these products sell the most. These are the highest margin products. These are the products that we're going to focus on. That's how they work. Not, these are the products that patients need. Here's some small market products that really should be in the market, but they're not a margin driver for us, so we're not going to waste our time. So I think when you look at overall health of the program, protecting some of the processors, the local groups, it's important for the patient program.
Awesome, thanks, Justin. Rachel, looked like you had something.
Thank you.
I just thought it'd be important to add that, should it go Schedule 3 in, let's say, July, it'll take a few years for products to actually get approved, go through clinical trials, get FDA approval, and actually show up on shelves. So there'll be some time for state regulators like those in Utah to adjust and make whatever,
Necessary changes. So you think
Right.
you have time to.
and to consult with attorneys and to make sure things are solid with whatever.
Let's be clear, there are
I was
already
gonna say,
FDA approved
they're already
drugs
doing.
already that
Yeah.
are manufactured
Yeah.
at scale and sold in every CVS
Yeah.
law.
Yeah.
So
Yeah.
those become the products that are now covered by your insurance that
Yeah.
every person in traditional healthcare is given access to, synthetic products that aren't the real products. It's the catch-22, guys. Reality.
But I believe those can be counted on one hand. I mean,
Sure.
right?
But they will.
We
be
know
the ones
exactly what they are.
Everybody is buying, and paying for it, the only ones that doctors prescribe, while the rest of the industry plays the waiting game.
Yeah.
And there are significant studies that show that these products have adverse effects that you can see.
And that would just take like the market, right? Patients will realize and they'll buy the product that works for them, right? We hope. It's just hard when insurance is covering it. One thing that I wanted to add, and I'm like 0% protectionist. None of this to me is like, oh, I have to protect other people's product. But I will say, so like what I've said before, just because you're an MSO doesn't mean that you're inherently not going to care about patients. So I don't want that this to come across as this, but I will say that in working with the companies that have come from out of state and working with the ones that have been local. Like I can call these guys back here and I have done it to all of them and like, hey, I have a patient, they need this type of product. I mean, Dragonfly came out with oral sprays. I mean, come on, because we had a couple patients who needed them. They will match products to patients, even if it's one or two. And it has happened time and time again. If I've called the ones that are not from Utah, and maybe this is just anecdotal evidence, it has not worked the same. And that's just what I've seen. Again, I'm 0% protectionist in this. I don't think that that's the main reason why I'm looking for a cap, but it rings true a bit for me.
Okay, we got one more public comment, and then we can bring it back to the board because of our past time on this. This issue we'll bring back for action after this public comment.
I got a couple things too, so to Ded's point. Being a smaller group, like some of us locally, we're comfortable, so we don't have to go through the channels of legal and corporate hierarchy as some other larger groups do, so that's why some of the smaller groups can do some things. I don't think the main focus of the combo is MSOs versus everybody, because that is a little discriminatory. I do want to shed light on a situation where, while this isn't, I appreciate Chris's position on being patient focused as a QMP. I think having the processors inherently, indirectly will protect patients, as if you have an independent processor right now, who doesn't have access to biomass or doesn't have access to distribution. As a retailer, I'll get phone calls from independent processors, and I always try to honor the independence to make sure that they have space to live on shelves, because we could choose not to, but I think being local, giving individuals an opportunity for the market to dictate, will their product sell? If we bring them on, if they don't sell, then that's another story. But you have, with new processors coming on, there's only so many patients. Patients are only consuming so many products. So just being mindful of new entrants in the market, they're all fighting for the same bio, and they're going to be fighting for the same shelf space. So I don't know what that does to the patient down the road product, but this perspective is more so from an operations perspective, where we as an industry don't want to set people up for failure, saying come into our program, pay a fee, and then not have anywhere to sell your products. Because if they're not well capitalized, we're setting them up for bankruptcy down the road. So just being mindful of not setting, everyone has free will, anybody can get a license if they want to, but by setting them up where they think this is going to be a retirement plan or a gold rush, I've seen in other markets, so just.
Thank you. All right, with that, unless we've got anybody else online.
We have one person.
Yeah, Frank, we'll go ahead and unmute you and you'll have 2 minutes.
Okay, thank you. Can you hear me?
Yes.
Yes.
Thanks. Hi, this is Frank Morris. I'm the CEO for Life Elevated. I appreciate that you gave Justin the time, and he's certainly the guy to ask questions about from a history perspective and a patient perspective. My perspective is, look, we're an independent processor. We are one of those 4 independent processors. We are stuck in the middle of protected businesses that have a protected license and a market on the grower side, and a protected environment on the pharmacy side. And we would benefit from having licenses capped. There's no doubt. But I think our benefit is that the patients would benefit. It would provide us an opportunity to bring in some more capital, because we do need shelf space, and we need capital that can help us to continue to grow. But we also need our partners on the pharmacy side to open up some of their shelf space where they are no longer a part of what was the original legislative intent of a healthy 3-tier system. I don't think anybody contemplated from the legislative side that you would have one MSO own almost a third of the pharmacies in the state. I don't think that's a healthy metric for the state to have. And then we could tick off all the others that have multiple pharmacies. Some of our Utah-based partners are very good to the small processors. and some are not. So I think you really need to, I don't think we should be afraid to cap the licenses. You can always make changes. Certainly not, the legislative intent, not afraid to cap the growers, not afraid to cap the pharmacies. There are metrics in place to be able to grow those if necessary or expand the licenses. So the world's not going to come to an end if you cap the processors, and it is going to help those of us that are in the middle to be more competitive, to be able to access more capital. Thank you.
So thank you, Frank. All right, with that, we will close public comment and we'll bring it back to the board for potential action. Does anyone feel like you need any more information? Do we feel like there's things we're not considering? I mean, I know Missy would bring up a point, but I'm not sure that that necessarily is entirely relevant to whether we vote for, go for a cap or not. I mean, I guess I don't want to take like proxy votes, or kind of like free votes, but the question is like, what motion do we make here? I mean, do people, if you are in favor of a cap, are you in favor of just a hard number? Is that the current number, which is 15? Or is that some number above 15? Or if it's, we replace the cap where it is currently with the ability to study it, or you do it above 15 with the ability to study it. That's, I think, where the real question, lies. I think we've heard good arguments for capping versus not capping, but now the question is, if we do decide to cap, how do you make the decision? Or is it something that you recommend generally capping licenses and then leave it to the legislature who's gonna have to take care of it anyways, because this is statutory. So
What about if we, just look at number 2 and say, like, we're gonna look at setting a program with growth and measures and triggers, which would, also probably cap it, right? Because we're in a good place right now, but looking more towards just the program in which they would issue more licenses.
but isn't that really the study?
Yeah.
Well, I think the hard thing with doing the metric, right, if you were to look at last year's patient count of 72,000 versus this year, I mean, we almost went backwards. I mean, what happens if you go backwards and you lose a processor? You say, I'm sorry, you're the last one, you're gone now?
No. And we take the first one off.
But I mean, I think there, I mean, at the end of the day, is what we're telling the Utah patients is, yeah, we understand that there's protections we want to have you have access to your products. But I don't feel that they haven't had access to products. It's the availability of products at pharmacies that has been the issue. These processors are still making their products. It's just whether or not it's available throughout the state of Utah.
Some patients do though complain, not to jump in, but they do complain that they have like parts or something that they feel like they can buy out of state that work, and then they're not buying them in this state and they're working the same. So not the product, but the product that's working. So that would be some.
I know we had a discussion, can't remember what board meeting, but that's the type of feedback that as pharmacy, that they need to be getting that. Do we share that with the processors? I mean, that's not for this agenda item. I think, that's kind of just my thought there, when you bring that up, is I mean, that's an entirely different topic, but I don't know if that's necessarily saying, hey, if you say vote the cap, and to your point, well, maybe that processor in that other state has a great way to formulate their vape cartridges, and that's why it works so well. So now we're telling them, sorry, don't come to Utah.
Yeah.
I mean, and that's my concern. Is, I can fully be behind and say, hey, I mean, be self-interested and say cap them, because I have a processor. I don't have retail, and I want to know it boosts the value of my company, but also protects entry. But I feel that it's always been that way. I mean, and that's why, if we make a motion today, it's either, I think it's essentially on whether or not we keep it the same or cap it. That's what it comes down to. So, I mean, I know where I stand. I'm probably gonna make a motion, but
Rather than do a soft cap, trying with some sort of growth.
yeah, I just.
I mean, the soft cap's the same thing. Soft cap is gonna allow
Yeah.
you to have to study it in the same way they would study pharmacy licenses and cultivation licenses, right? That's the idea of the soft cap.
Right.
The metric is a bit different, right? Because the metric is then just triggered. Neither Cody nor Brandon has to do anything other than once it hits a certain patient count or whatever metric we choose, that's more of an automatic, trigger. We haven't done that with other licenses. Even when you all enacted criteria, right, in law, that was not the discussion at the time. So I think if we are gonna do that, you're probably then gonna face the same discussion for pharmacies and wholesalers. And I'm not saying that's wrong. I just think there will be a ripple effect that
Yeah.
you'll probably have to change it, for others. So, I mean, I do think Matt is probably right. Like, I think it is, at this point, I don't feel qualified and or like I have a number in mind other than the number we currently have, right? Because I could say 18, and you could say, oh, that means we could bring 3 more in. There's no reasoning behind it. There's no analysis behind it, right? So to me, I feel like about all we could say is we either vote in favor of some form of a cap. And we could qualify it to say a soft cap. That's probably about all the further we could go, or it's a no cap. I really think that's about the best we can do as a group without just being completely arbitrary and picking a number. You know what I mean? That's just how I feel. So that to me, seems like, where you would beautiful, but happy to be, I'll have anybody, chime in with anything else.
You want us to just make a motion?
That's what it's time for. So that's why.
I will make a motion to cap the number of processors and disallow the unlimited number of medical cannabis processors. That makes sense.
Okay, we have a.
Stop that and to move forward with. I want hard cap. I'm doing soft stuff.
Okay, all right, we have a motion to place a hard cap on medical cannabis processors in Utah. Do we have a second?
Should we specify hard cap as in a specific number?
Sounds like,
As in right now at 15 where we are?
which means no growth.
That would be the
So we
department's
change
job.
our law changes.
No, that's
No.
but I.
So that's
I would just
soft.
remember we have more than the statute is going.
I guess it's 17 with fancy reason to us, okay.
Really? Okay, that it's soft
Let's just go
cap.
to amend.
I didn't realize that that soft had a
Glad I
legal
saved-
definition. Okay, now we know. So, move forward with the soft cap, no. We're doing the same one, but soft cap, not hard cap.
Okay, so we have a motion to put in place a soft cap, meaning that there would be a number that they would choose, similar to pharmacies and or cultivators, a number that the legislature would choose, but it would allow Department of Agriculture and Food, similar to cultivators and pharmacies, to study it on an annual or more frequent basis to determine if more are needed. Does that sound like the motion?
That's well said.
I second that motion.
Okay, we have a second for that motion. Abby, will you take the roll call vote?
Ken Anderson,
Yes.
Nanette Beresme, Desiree Hensky,
Yes.
Jimmy Higgs,
Yes.
J.D. Royson,
Yes.
Chris Morgan,
Nay.
Matthew Page,
No.
and Misty Smith.
Yes.
All right, the motion passes, not unanimously, but with the required majority. All right, we're going to move on to our next item on the agenda, which is item number 6, which is medical cannabis dosage forms. This was continued from last month's meeting, so Chris, don't know if you had a chance to review what we talked about last month. We discussed last month more broad form factors. And we actually made a recommendation to, that the legislature approve suppositories as kind of a broader form factor. This one is a little more nuanced. This is kind of expanding on current existing form factors. And with that, I'll turn it over to Trevor for his presentation.
Alrighty, thank you, Chair. Let's go ahead and start. So quick outline of the presentation, we'll talk about, I think a little background, actually, I forgot to add here, but we have a background slide, I believe. We talked about medical cannabis dosage forms allowed in other medical only states. Edibles in the Utah market, what's currently allowed, infused chocolate and other fat containing dosage forms, but going to do a bit of a deep dive into chocolate, concerns with adding additional dosage forms And finally, some potential recommendation options for the board. So the background, as JD stated, I guess I'll get to that in a second, but the basis for the proposal is there are dosage forms that are not allowed in Utah's medical cannabis statute that could benefit some patients more than existing dosage forms. So at the last board meeting, there was a 5-2 vote for recommending that suppositories be added to the list of medical cannabis legal dosage forms. And the board also made a vote to table consideration to this meeting for new dosage forms, or at least consideration thereof. So dosage forms allowed in other medical cannabis only states. In the appendix of this memo, which everyone should have, you'll see on that last page a list of every, at least by my research and in the statutes of other states, every other medical only state that has dosage forms that Utah does not have listed in our statute. So out of those 16 medical only states, 9 of the 16 have dosage forms that aren't allowed in the Utah medical cannabis program per our statute. Florida, Oklahoma, and Texas have no limits on dosage forms. Texas, I guess the little asterisk there is it can be consumed in any way except for smoking. But otherwise, Florida and Oklahoma, Florida has approved routes of administration, not approved products, and Oklahoma has neither. The remaining 6 states have laws that allow for only specific dosage forms to be manufactured. And in my analysis, the 3 most common forms we saw in other states were suppositories, smokable flower, and various edible products. And again, feel free to look at that table in the appendix for more information on those specific products. Edibles in the Utah market, this is the list of what our law allows for with some examples. And so example, tablets that could be like mints, dragonfly makes a mint, I believe. Capsules, which look like conventional pills, liquid suspensions, which are often tinctures with droplets, sublingual preparations that could be tinctures as well, or strips, syringes, and gelatinous cubes, as they're affectionately known, but are allowed to be called gummies under the administrative rules. And that is the most popular edible product in Utah, would be gummies. So to show infused chocolate, I'll say that the memo goes a little more into a few other dosage forms, but it seemed that a lot of the interest that I was able to garner, as well as from the board's previous conversation, was around chocolate. So that's why we're going to go specifically into chocolate. But here's examples. On the left is a infused chocolate piece from Florida. In the middle, that's medical cannabis chocolate from Texas, and on the right from Hawaii. And as you can see, they come in different forms. In Florida, Move Dispensary, it's called. They have specific pieces. Good Blends is the brand in the middle, or the manufacturer. Heights is their brand. They do almost strips, rectangles, and then on the right you have almost little. They look like gumdrops to me. But infused chocolate is sold in the Florida, Hawaii, Mississippi, Oklahoma, and Texas medical cannabis markets. It's explicitly allowed in Hawaii and Mississippi, but as I said, Florida, Oklahoma, and Texas, it's basically a free-for-all in terms of products. So naturally, they're going to come onto those markets. So what are the arguments for infused chocolate? The claim that I heard in speaking with various members of the industry is that cannabinoids like THC and CBD tend to more easily combine with fats and other lipids. They're lipophilic, so they're attracted to them. Chocolate is a high-fat food, and when chocolate as a high-fat food is eaten with cannabinoids, it may increase their absorption and bioavailability or access to the human body, meaning less of the cannabinoids go to waste, as they're deteriorating in your stomach acid, and more is actually able to be introduced to the human body. So the other claim is that chocolate may simply benefit some patients with eating or sensory related concerns because it simply has better flavor and texture than dosage forms. The memo mentions elderly patients, like geriatric patients, who are very picky with what they want to put in their mouths, and chocolate may be more palatable for them. For example, I mentioned Viactive is a common calcium supplement sold at every drugstore, every Walmart, every Smith's, that is meant for people young and old who want to be able to consume their medication in a more palatable manner. Regarding sensory related concerns, you can think of folks with autism or other neurodivergent conditions that may have issues swallowing an oil or chewing a gummy, having an issue with the gelatin. Let's go ahead. So before I get into, and the memo speaks to these two studies that I cite, they were both provided by Kristen Rigby, who's the pharmacist in charge at Block Pharmacy. She has an advanced degree in medical cannabis science. But I would like to preface before briefly mentioning these two studies that I don't believe, I'd be remiss to say I'm not the proper avenue for academic literature review. The Cannabis Research Review Board and Lauren Heath, who's a pharmacist that the Center for Medical Cannabis contracts with to review academic literature, is a far more logical choice for ensuring that the validity of these studies are worthy of the board's consideration. But nonetheless, I did work with some folks to try to vet these two studies specifically. There's more than just this, but I wanted to mention these two studies on the left. This is a 2016 study where researchers administered THC and CBD separately in a lipid containing and a lipid free solution to see if fat actually helps transmit cannabinoids into blood. And the results were a 2.5-fold increase for THC and a nearly 3-fold increase for CBD in the lipid containing solution. So the conclusion there is the amount of lipids present in cannabis containing foods may lead to an increased systemic exposure to those cannabinoids. The right was a more recent study, although be it less controlled. Researchers administered nearly pure CBD capsules to 8 volunteers in Minnesota. These capsules were from a medical cannabis brand in Minnesota. One group had no breakfast, the other group had a fatty breakfast, although they did not test a low fat or a no fat breakfast. But the results published by University of Minnesota that when compared to fasting, taking CBD with that fatty food increased its bioavailability about 4 times on average compared to that no breakfast group. But again, I think more research is necessary in order to make a definitive conclusion, or at least as definitive as we can with the given studies for this board. Nonetheless, this research did seem to be relatively highly controlled, except for the one on the right. That one's not quite as powerful. And I'd like to encourage the board to consider if it wants to continue to review this from the scientific realm. It's a possibility that we may be able to ask Lauren Heath, the pharmacist that we contract with, to do an academic literature review and present to this board with more certainty than I can. Let's go ahead, Abby. Thank you. So some concerns with adding additional dosage forms primarily revolves around appealing to children. Department of Ag statute requires that processors cannot create products that, I believe the language is, knowingly or inadvertently appeals to children. And whether or not chocolate inherently appeals to children is contested among people. I heard in my conversations with folks that a gummy could be just as similarly interesting to a child as a piece of chocolate. It can be a manner of debate for people. But infused chocolates and other products that have conventional pieces that may be appealing to children could make the Utah program look more recreational than medical, according to some. So I wanted to mention both national and Utah statistics on edible cannabis product exposure to children. There has been a substantial rise in accidental consumption. I believe the number, it's not on this slide, but it's from 2017 to 2021, there's been a 1,375% increase in edible cannabis product exposure in children under 6 years old nationally. And while cannabis companies pharmacists, bud tenders in recreational states, public health officials very often urge people to be safe users of their cannabis products and to store them effectively. People don't heed that advice always, and that's why we see, as a natural consequence of cannabis becoming more available in legal forms, these risks of acute cannabinoid intoxication in minors. So in Utah, the Utah Poison Control Center reported, and I pulled this from their website, I don't know how recent this has been updated, but they reported, while there's a small number of exposures to edible cannabis products in Utah, nearly half involved, or I should say exposure to cannabis products in Utah, nearly half involved cases of edible products. These could also be edible products coming in from out of state, from recreational states. They could be hemp-derived products. We know those are way more accessible to children. But nonetheless, I thought the board should be aware, as this was a vital concern for some stakeholders I spoke to. I also reached out with the help of Minnie Medeo, who's here today, as well as Kristen Rigby, to all of the 15 pharmacists in charge to try to garner some thoughts as to what are dosage forms they believe were missing or that patients were asking for. 9 of the 15 were able to join for a brief roundtable, merely to gather their thoughts, not to take a consensus or a vote. But these were 4 points that I wanted to share with the board. There was general support for chocolate as a dosage form. Some PICs mentioned that patients have been asking for it for a long time and actually attempt to make it at home. One PIC mentioned to me in private that they have a caregiver that does this for an elderly patient that won't eat gummies. Support for individual pieces rather than chocolate bars. So for example, in Florida, and you can see on the list in here, they have a variety of edible products that are legal. However, they all must be individually wrapped, as opposed to in a container, all of them like we would have gummies in Utah. So there was more support for individual pieces. There was not as much support for individually wrapped pieces, because there's, it's obviously a higher cost for the producer, which would inevitably go onto the patient. How high that cost would be, I cannot say. And then finally, there was support for flavored chocolate. This could be things like fruits, nuts, ginger. The PICs tended to believe that because gummies can be flavored, chocolate should be just as it should be reasonable to allow it there. And it may additionally increase the ability for folks to have it be more palatable. So yeah, anyways, those are those thoughts I wanted to share. Finally, I know this is a long list. Number 2, these are all the products that are not allowed in Utah, but are allowed in other medical only states. So I simply wanted to share them with the board in a long list and say, here's all the options compared to fellow medical only states. But number 1 is you could recommend not to allow any additional forms. Number 2, you could consider specific dosage forms as listed here. Or number 3, you could request that the Cannabis Research Review Board, or that myself attempt to work with Lauren Heath, the academic pharmacist, to come back to our board with scientific literature reviews on specific dosage forms, such as the ones listed in 2A. And with that, I will turn it back and happy to answer any questions.
Excellent, thanks, Trevor. Does anybody have any specific questions for Trevor before we?
What were the other half of the poison control calls? Like, I would have expected almost all child exposures to be.
They didn't, Poison Control Center for Utah didn't list it. So I cannot say. They said, yeah, it often depends on how the reporting party, if they actually say.
We're making it, yeah.
Yeah. It's really what they said, but people report, sometimes they don't. So that's only the data that was available, unfortunately.
Surprising to me.
Or in a baked product.
Homemade products.
Yeah, that's not a base part or something.
Yeah.
I was gonna say, my kid drank peroxide like 4 times, so I don't. think
Mine, it knows how to use the cartridge.
Yeah.
Could I make a quick comment that builds on this a little bit? Is there are some states that don't allow the dosage forms that we allow.
Right.
For example, flour, that's very common in a medical state that's prohibited. Gummies, some don't allow gummies.
Correct.
So while some states allow some things we don't allow, other states don't allow things that we allow, so.
That's correct. That 9 of 16 that allow other forms that we don't, the remaining, the 6 or the 7, have less than Utah has. I should have clarified that. Thank you.
And one thing I'd like to point out before we all get talking is the reason why these things are not on the list right now is because they wanted to make sure that it was something that would be normally sold in a pharmacy. So even though like flour isn't, they were, anything processed, they wanted to be like, okay, is it a pill? Yeah, produce a pill. They understood that gummies were kind of grandfathered into the cannabis program, and so they allowed those, but beverages, cookies, brownies, it wasn't just appealing to kids because they did have child-proof opaque containers, but it was also because that is not a medical dosage. So what we'd be asking is to recognize these as a medical dosage form, right? Like because of the fact or because of a reason, that's gonna be the pitch to the lawmakers, is making them understand these as medical dosage.
And I think the first person I'd like to hear from, I don't want to spot too much, is Misty, right? Because I feel like if we punt this back to the CRRB, the reality is it will not come in front of the legislature this year, and I'm not saying that's the wrong decision, but that means it's 2025 at the earliest. We did not decide to do that with suppositories, right, as a board, so there is precedent to do that. But I'd really like to hear from Misty, because when she and I talked after the meeting last time, she, I don't want to put words in her mouth, but said that chocolate at the very least, seems like that might be one that CRB could stand behind.
Well, I can't speak for the CRRB, and I think that, having looked through, the literature in response to a call from Trevor, it is limited. There has obviously been an increase in the literature in more recent years than farther back searches, but I mean, it comes down to the lipophilicity of the products, and it's just pharmacology that you have better bioavailability in a lipophilic solvent for the preparation. So I don't know how much information there would be for the individual products, because I didn't see it. And I can almost guarantee there won't be controlled clinical trials. What you would see is more basic science, preclinical research. Angela Birnbaum's, who is actually a good friend of mine, who did the study with cannabidiol that was cited in the draft. She's done a number of articles on cannabidiol. And that's a well-done manuscript, but it is in no way a clinical trial that we would consider through the board because of the limited subject size. But there's still value added information there. And I guess I would say that from a pharmacologist standpoint, it makes sense. And we could put it before the Cannabis Research Review Board. I'm not sure how much information is out there that they would be able to.
Because there's a good chance that there might be no studies.
Exactly.
That meet your academic rigor.
Exactly.
And therefore you wouldn't study.
That meet the clinical trial.
So you wouldn't necessarily issue a negative stance on it.
No,
You would basically just say.
there's
can't
not
have
enough
opinions on it.
information, unfortunately.
But generally, in line with some of those studies that Trevor showed, cannabis when consumed either with a high fat meal or
Yes.
form that's higher in fat. Is there research out there beyond that Trevor showed?
Dr. Birnbaum's study is a good indicator that, even much of the early work that was done with Epidiolex and its tincture preparations before it became Epidiolex. When you increase the fat content, you got better bioavailability in the compound. Yeah, I mean, there is literature out there to support that in basic pharmacology. As far as the other preparations, I didn't look into anything besides the chocolates. I specifically, at Trevor's request, looked into that.
Mhm.
And it all came down to lipophilicity. The higher the fat content, the better absorbance.
And for what it's worth, even though it's purely anecdotal, a couple of the pharmacists in charge that I spoke to said they had patients report having a cheeseburger, going home, using, and had way more noticeable impact of the product, even though again, totally anecdotal.
Yeah. I can say that I know moms and caregivers and that make chocolates. A lot of them make honey, a lot of them make infused oils and butters. I do know one mom that makes like a butter syrup, like. So, and it's to, you know, it's for to make it palatable, right? And so, it's hard for me. I'm not gonna lie, and that looking at these and not seeing recreational products.
Yeah.
And that's, I think, my hardest part is just kind of trying to push down that bias a little bit and say, what is necessary? We can show at least with some evidence that having that, those fats, like with glycosteric or whatever, like they have, it's gonna work better. So I don't know. I mean, I know that we got a lot of pushback when we had beverages. I think asking to push beverages again could be a problem, right? Or at least we're gonna get pushback. So, you know, just, I don't know, what can we? But I'm just thinking, for me, it's hard. I like pushing away my biases and just saying what is necessary. And I do know that, like the honey, the oil, the cookies, and the chocolates, the brownies. I know people that are making those already. I know one mom talking about making honey for her kid. She's able to just like dissolve it and put it in water, and that's enough to stop seizures. And then he'll drink it because it's sweet. And it stinks up her house. She says making it is just incredibly smelly. And she's like embarrassed to have people over for like the whole like 48 hours after she does it. Like, and so I feel for her, right? Like this isn't what she wants to be doing. And so we need to maybe just look at that and from their perspective and say, yeah, like making these at home, some people are capable of it, but it really is, it's a hard job and it smells.
Would that essentially be more of a tincture though? Because it essentially should be extracting it. And then,
Does she infuse it? She infuses, I know she has a little, like she cooks in like a crock pot for, she decarbs it and then she sticks it in there and infuse it. And then she strains it all out and then she just puts it in as water. Not what I saw me doing in my child, so.
Yeah.
Well, I think one thing I want to say too, and I just say this, just because a product is available in a recreational market does not somehow make it inherently recreational. Right? Cannabis is cannabis. And I think what I've heard here today, from Misty is there is some evidence out there. To go back to the papers we were all talking about before the meeting started, right? When talking about rescheduling cannabis, HHS said, is there at least some scientific evidence, right, that it has a medical use, right? You know what I mean? So I've heard here today, that there is some scientific evidence out there. We may not have as much as we want. It may not be the quality we want.
Yeah.
I don't think that's for a lack of trying and for a lack of wanting. Misty and I have talked about this.
Yeah.
That is largely because the federal government continues to recognize cannabis as a Schedule I drug completely inappropriately. Now, hopefully some things will change on that front, but for now, that's where we stand. So I've heard here today, it sounds like there is at least some medical evidence that higher fat foods are better carriers for cannabis. There's better absorption, you know what I mean? All those things that we've heard here today. So we probably don't have enough, in my opinion, to say necessarily honey maybe is kind of right on the cusp. Maybe even some of these sugar or syrup, you know, confections. You haven't heard anything about beverages, powder mixes, which I would love to see those, you know, and different things and syrups and those things as well. But it does sound like we've heard at least there's enough support for chocolates. I get cookies, brownies, and other infused baked goods are going to have optical problems. I understand. You're going to have lawmakers that are not interested in introducing those kinds of things. I think chocolate's going to have some optical problems. But if that is better for a patient to consume it in that way, that is part of getting rid of the bias around cannabis that just generally exists. Just because it's in a chocolate form doesn't make it more inherently recreational. in my opinion, it doesn't make it more inherently appealing to children. If that's a better way for a patient to consume medicine,
Yeah.
and we're all talking here about what's best for patients, that's where I think we should land on. Regardless of whether the optics are ultimately gonna fail in the end, let the lawmakers tell us they think this is too appealing to children. Let the lawmakers tell us they think it's too recreational. We're sitting around this table pretty much in agreement that we believe that there is some evidence that this is going to be good for patients. We're hearing stories of people doing this already. So to me, whether we say cookies, brownies, and other infused baked goods, and we go that far, or some of these others, I do think there is some medical evidence, and that appears to be the standard for rescheduling. And to me, that's a good enough standard for the federal government to use in relation to rescheduling. I think it's a good enough standard for us to use, as a board, in my personal, opinion. So anybody else from the board has anything? Rich will continue second. I want to hear from the rest of the board because we do have quite a bit of public comment on this and some people that I really do want to hear from. So board first, and then we'll go to Rich, and then I do want to get to public comment.
I think, it's concerning that people are, obviously, I know what happens, but the fact that they're actually making their own non-approved products. Because at the end of the day, them taking flour and extracting the cannabinoids and decarboxylating and then, remediating all the solvent. Once you start extraction, you're concentrating anything that was in that plant.
Yeah.
There could have been pesticides, there could have been heavy metals, other things that become concentrated that can be, have adverse effects to patients. Because I'm guaranteed they're not taking their honey that they just made and getting it tested at the state to see how clean it is.
Cody, do you provide that service?
There is.
I know any lab will test it. I understand that. What I'm saying is most home users aren't doing that. I think people just want access to good, clean medicine. It's just well known that chocolate does provide a way, even and we talk about chocolate is available as a way to take other medications. It comes, I know I have several friends with highly autistic children, and the only way they can take some of their medications is through chocolate. That's it. And it's worked for them. I don't think, me personally, I'm not gonna be asking for cookies and brownies and other baked goods and anything else on this list. I don't think that's there. We just took beverages off to reintroduce it again, but it just doesn't make sense at this point. But whether or not it's there, I think statutorily, we need to get that changed to allow an additional dose form, so that way patients have access and don't feel it.
All right,
Oh.
thanks, Matt.
Also a reminder that this will all, everything that I have a hard time, because like I said, this looks recreational, but I also have a hard time with us sitting here and splitting hairs and saying, this makes me feel icky, so maybe you can't have beverages, right? Like, we need to be providing the products that work. And if it works for them, then let's find out what is true medicinal products and let's approve those things, at least through this board. But just, it's also, just we need to remember that whatever we approve, whatever we say that can be produced, is still going to be in childproof opaque containers. So it's not going to be appealing to children because they're not going to be able to see it inside of the childproof opaque.
100%. I don't think
So,
anyone here is gonna argue that somehow we package chocolate
Like all of a sudden,
in a completely different way than we package done is currently, right?
I think I was thinking it for the lamb.
Tell us how we package it.
Yes.
I already know,
If-
no matter what my ideas are.
If I could add one comment, I had actually shared a review with Trevor that I think is discussed in here, but not included in the references that were shown. But it actually goes through, it's from the University of Massachusetts article in 2019, entitled Enhancing Efficacy, Performance, Reliability of Cannabis Edibles, Insights from Lipid Bioavailability Studies. It's not necessarily a standalone study, but it's actually reviewing what's in the literature from the studies that are available for review. So I don't know if it would be worthwhile sharing this amongst us and having everybody look at it and then maybe coming back with a more informed status in order, and then having this vote. But it basically overviews what is known in the literature. That would be my suggestion.
Certainly.
Trevor already has the reference.
Yeah, I have that study.
Share it with
listed.
the
And I think one thing in the future, if you are, if you do share those, I don't blame you for sharing directly with Trevor.
Yeah.
Just might as well share it
Of course.
with the group, right?
Yeah.
And, we probably could have reviewed it, beforehand, but that's, I look, the more research, the better, the more we can all understand, the better. But, if anybody from the board has anything additional, let's speak it now. If not, we do have, at least 4 people that are prepared to comment on this.
Just so it's obvious, I mean, as a parent with a child with a card, I do make my own oils and it is an undertaking, it is a task, and it would be really nice to have access to something that was convenient that I could just go pick up like anyone else does at the pharmacy.
Well, and I will add as speaking as a caregiver myself, of a mother with Alzheimer's who has difficulty swallowing. Some of these preparations, the compounding that pharmacists are able to do with some of her other medications, I don't see why it shouldn't not be an option for cannabis products as well.
Okay, do we have anybody online?
Could I just make a quick
Oh,
comment?
yes, go ahead, sorry, Richard.
One thought I was thinking through is the packaging.
Yeah.
The packaging makes, no matter what is inside, what the packaging looks like, sends a message to people that buy it. And there's some language already in UDAP law that talks about appealing to children, and there's some basic restrictions that are no-brainers, I think, that you apply as we enforce that law. But one option is, okay, for chocolates, though, we're gonna make it even stricter. I'm not suggesting this, I'm just brainstorming to say white packaging, black lettering. If you're gonna sell chocolate, you're gonna sell it in a white package and black lettering. And you're gonna make it look like an MRE. Okay?
Sure, definitely.
Now, when I go to the pharmacy, what do I see? I don't see a bunch of fancy packaging. I see basic, very basic, every time. But as I look at counters, I see cough syrup that looks pretty. I see all kinds of, stuff that you buy at Walgreens that I don't need a prescription for, right? So if we have concerns about the packaging and how it's presented, which I think some of us do, that's one option of addressing that concern. Doesn't change what's inside, right? Also the color of what's inside. I do not ever want to eat white chocolate. So if there's a requirement that it be white, I'm just saying, it just doesn't look good to me, right? But it may address concerns that some people may have when you, about the appearance of chocolate, right? You still get the value that we've discussed. Now, gummies are already out of the box, right? I mean, the statute says appealing to children, but there's some colors, there's some presentation that makes things look nice and appealing to a regular consumer, right? To patients. We don't require a white sticker with black lettering that's an MRE or like a regular prescription. That's not what the law says right now. So I just thought those should be factors that are considered.
Yeah, and I think another factor that should be considered is the education that we put out to consumers of medical cannabis around how to protect their children. Right? I think a lot of these things, as kids are getting into these, whether it's a floral package, whether it's a cartoon package, or whatever, a lot of that to me goes back to public education that should be put out. And Trevor did put this in the memo around cannabis and making it responsible and having the cannabis conversation with your children, responsibly locking that cannabis up. Because it won't matter what kind of package it's in. We could pull the most rec looking package possible, and we could do black and white packaging, which at one time, there was a producer in this room to my left who did all their packaging in black and white, right? I don't necessarily think that, I think it's worth mentioning But I think educating people on how to protect their children from, consuming cannabis is just important, if not more important than what the packaging looks like. Because ultimately, it's always put the onus back on us as producers. And I'm not saying, no one in this room is asking for wild packaging, at least from my perspective in our company. I don't know if we've ever submitted anything that, is been deemed inherently recreational as a company. We've had to make some tweaks and some different things. But I think it's important to make sure that if you're gonna put more onus on us, there should also be better education to the public and put the onus on those patients to protect people from consuming cannabis as they should. So if anyone on the board has anything more, anyone else wants to comment, wonderful. If not, we do have 4 people in the room. Trevor, go ahead.
I just wanted to share as we talk through packaging, kind of the left and the right examples here. I would believe if chocolates were to mirror how gummies are treated in Utah, it would be like on the right. Individual pieces as opposed to a full bar and in a secure container. And this does include sort of what Rich was saying, black and white. We don't see a lot of overt advertising here on that packaging. And then on the left, we have the actual individual piece deliberately marked with the THC diamond, which is a relatively universally accepted symbol, and individually wrapped. So obviously the thought around that is, well, if a child opens up the package on the right, they're seeing 20 pieces of chocolate versus on the left, even though there's more packaging, more waste, more cost, each piece is wrapped, right? So infants are gonna have a harder time getting into that. So I just wanted to show these as visual aids for the board when thinking about the optics of what kind of packaging may be more acceptable and helping to show it as a medical form, if that's where the board's going.
Well,
And
certainly.
the one on the left is scored.
It's
So-
deliberately scored, yes.
Yeah, and I think Brandon and Brandon and Cody both have a ton of authority what to do with packaging. So if they determine that chocolate needs to be, somehow, regulated more heavily from a packaging perspective, we probably can do that, right?
You need authority.
I'm not sure we would be able to say
They
white.
not allow you to delineate between or is it just, it's just general packaging requirements, right?
Yeah, I'm not sure we could go as strict as just saying white label, but, or white, black and white label.
No, I understand. And look, I think the standards you all have come up with, even though they change quite often, and I believe you reported on your 400,
We were forced to do that, by the way.
Yes, I understand. I know it wasn't your choice as an individual, but I'm just saying, you all have shown the ability to enact further protections from a packaging standpoint if needed.
Those Hawaiian looks like really good. by the way. I would eat that whole, pretty sure, just by accident.
Let's get Brandon. All right, I do want to, another one online that want to talk. No. Doesn't look like it. All right, we will turn to the room. Looks like Tim Pickett is first.
Thank you. I'm Tim Pickett. I represent Coyote and Nate. I was here last month and we take care of just over 15,000 Utah cannabis patients for service. It's kind of double-edged. I think that this is, from our standpoint, in our education for our patients, we commonly, in general practice for us to tell patients that the cannabinoids are lipophilic and to add fat to that consumption edible from an edible standpoint will enhance the effect. It's very common. We are constantly providing education in that regard. I don't think chocolate adds a medical value because you can add fat to any consumption. However, I think that's just a point to make. We pretty consistently recommend chocolate as an alternative to a gelatin form because it's easier to consume. An Alzheimer's patient was brought up here, and in Alzheimer's, that particular patient type, chocolate is a very good alternative to a gelatinous cube. So we are in high favor of adding chocolate to it. It's easy to purchase. It is upon the patient and the parents and the caregivers to package it and to protect it in a way. JD and I have given a speech to a group of people, take kids away from from their parents, and we should provide better education likely, but, we would be in favor of adding chocolate specifically to the consumables list, in Utah.
Well, thanks, Tim. All right, Narek.
At the Dragonfly, in general, I mean, we're in support of basically any dosage form, and here's the reality, so. You know, we talk about recreational disposition a lot, and this is a point I have to address that. Cannabis seems to be the only industry we actually have this conversation and this narrative about recreational disposition. Nobody says you're recreationally using wine and beer, you're recreationally taking that Xanax and that Valium, and somehow cannabis, it's always recreational. And quite frankly, it's discriminatory and judgmental to say you're using that recreational. You trying to help your kid get an edible into their stomach's the only way, you're illegal, you're a bad person, you're recreational, you're not medical. And we force people to choose that every single day by prohibiting dosage forms. People, no matter what, if we weren't here in this room, people would be buying cannabis illegally, okay? If we didn't allow these dosage forms, they would still be making these products. We are putting people in a position to be illegal, right? And I think the goal and the mission for, Health and Human Services has always been to serve, protect, and advocate all individuals and communities. But we always find our way going back to somehow prioritizing one group over another. Protect the kids. Don't let these other people have it. Protect the kids. Which I get. Nobody is out here to hurt children. But it seems to be the same narrative. And I find it interesting that we're trying to provide data and science and evidence of why chocolate should be allowed, yet none of that was required for a gelatinous cube. It just seems like a moot point of what we're arguing, or even sharing data and science and evidence about, and we just run into circles, and ultimately it just comes down to opinions, right? What's recreational? And I still have heard any reasonable answer as to what makes something more recreational than something else other than protects the kids, right? Oh, let's just make this drink smaller and 30 milliliters concentrated in a shot. Somehow that's less recreational than taking a beverage or a drink. I don't know what that difference is, and we're gonna spend our time spinning our wheels talking about these things.
Mindy.
Hi, I'm Mindy, and I work for VA Pharmacy, and I've been a cannabis pharmacist during the school program. First of all, I wanted to make a comment of why edibles are so important to Utah. We have a lot of patients who are averse to inhalation routes. We have some limits on our access to inhalation routes. So the edible category is extremely important. I saw a recent study where 15% of all cannabis users did not get any effects from the edible product. And I'm sure you all know people like this. If you take an edible, it does not do anything. And science, we don't really know why, but we think it's either from the absorption or the metabolism. And so we need edible products that can have an absorption advantage. And I think I'm excited that we're talking about chocolates, and we should for sure allow them. But we also need to allow chews, something like Chiba chews, which I have tons of patients across our state lines by them out of state. They also have oil in them too, and they have a pulmonary advantage as well. But one thing I also want you guys to consider the word homogeneous in your what you're allowing. I don't really think cookies or brownies would be, in my opinion, medical, because you can't cut this in half or quarters and have that same consistency. Flavors should be allowed because that's exactly what a terpene is. A terpene is flavors. We cannot exclude them. So, and then as far as the comment to take it to the Cannabis Research and Review Board, it's just a pharmacokinetic fact that will need to be researched, and nobody will research it because nobody's making money for that. Let's see. That's really all I have. So just please consider not tablets, but the word chews. Chews, and if you look at Chiba chews, they do seem to work better for patients. Yeah, as far as the packaging go, individual packaging, I think we should treat it exactly how we treat gummies. And in my opinion, if they should be in shelf containers and not necessarily have individual packaging. Thank you.
Justin.
Lee Brand, I'm speaking on behalf of approving additional dosage forms, specifically chocolate. A couple of things. So when you talk about bioavailability of the cannabis product, that's typically driven by what's in the formulation. Gelatinous cubes can be difficult to add the right amount of fat content and keep the formulation stable, like whether it's temperature stable or whether they stick to each other. Some of those things can be issues. Specifically with chocolate, cocoa itself has polyphenols and methylxanes that are actually beneficial to the body. And specifically the polyphenols can be hugely supportive of brain health. And so as you're introducing cannabinoids into a system that upregulates and downregulates, polyphenols can be largely beneficial. Your liver has a portal vein that's largely receptive to medium chain triglycerides, which, you know, chocolate has a large component of. And also chocolate has enzymes. So when you talk about bioavailability, it's not just the amount of medicine that's moving through the portal vein, but it's also, and this is why, you know, certain individuals think that some people aren't as receptive to edibles, because there's a lack of enzymes, whether it's being produced in the liver, whether it's gut health. You know, some people's diet just isn't the same as other people's. And so you don't have the same amount of enzymes being used to process that product. And it seems to be that cocoa, chocolate, is a little bit more widely accepted in order to take that medicine. Specifically, when you're talking about children using cannabis products, you actually can see the same effect with the lower amount of cannabinoids when you're using chocolate to dose or a medium chain triglyceride. So that's my thing.
Okay, Justin?
Yeah.
Bijan?
I'll be quick to reiterate some of the sentiment. On the graphics that you had, the single serve score, a more recreational position, and the medical with multiple servings. Operating in other states pre some of the 10 milligram caps in California, they didn't require the individual servings on them. So I think the individual serving piece may add a little bit of cost to the processor, but I think it mitigates any type of exposure to a potential ingestion of a non-medicated person. Granted, you'll have different strengths, even individually, you have 5 milligram or 100 milligram, but it mitigates any potential further exposure. And I do think, to the chair's point about doing an education about keeping things safe away from the family would be in everybody's best interest, operators, regulators, and lawmakers. Lastly, I also do want to end with by utilizing the same rules and regulations to oppose a recreational position like we have with flower and some of these other brands that are in the market. I think there could be some additional guardrails, either additional warning labels, packaging restrictions. The only one thing I see about having everything one color and one thing is differentiation. So either as an operator, agents filling orders, obviously everything gets checked, but also patients. It could be a completely different product that looks so similar. So just not over regulating that aspect, but maintaining restrictions. Right now with flour, we can't use an insane amount of colors on the packaging. Only a certain percentage of the package can actually maintain our logo. So I think inheriting some of those similar restrictions would be wise on this new dosage.
Thanks, Bijan. All right, I think with that, we'll close public comment and bring it back to the board for potential action or further comment. I'm happy to make a motion. I might need Missy's help because it's gonna be a 3-parter. It's gonna recommend chocolates, it's gonna recommend chews, and then it's gonna have a little bit of an open-ended recommendation, and that's where I'm gonna need your help for the right verbiage on basically high fat routes to administration. That's, you know, that's it, because it doesn't say, hey, we're absolutely saying you should do cookies, brownies, other infused baked goods, but it does sound like there may be some other preparations you know, oils, butters, some other things I don't want to, you know, necessarily. So, I'm happy to make the motion. So I make a motion that we recommend that chocolates, chews, probably be further defined as needed, as well as, how would I say?
Going back to homogeneous, lipophilic.
I don't know if does that need to be lipophilic, I think it can be carrier,
Yeah,
but as long as you just, or any other, homogeneous substance.
So chocolate, chews, and then any other homogeneous substance? Or just chocolate and any other homogeneous substance? Does that work?
Because you got chocolate as an ingredient, choose as a form of the ingredients. Okay,
Yeah, where you could have.
I think you're gonna wanna narrow it.
It's not just.
right.
Could we just
Just
say like
like
any
advice.
homogeneous?
No, I was saying, that's it. I like that.
Yeah, defined as chocolates, chews,
Yes.
etc., oils, butters, yeah.
yes,
So just say.
because I think homogeneous is extremely important here.
Okay, so. Since you're probably better versed to do it, you see, assuming you want to make that motion.
Any homogeneous edible.
Any homogeneous.
Any homogeneous edible
Yeah.
dosage form.
Got it, okay.
Yeah,
Okay.
All right, so I make a motion that we recommend that any homogeneous dosage form, including chocolate, chews, and et cetera, be added to the list of acceptable dosage forms, medicinal dosage forms in the top.
do we need to say for oral administration?
Yes, or oral administration.
Okay.
You already got yours.
I'll second
Because we already did discuss very
Can
much.
I get it back in a second, for a second?
Sure, we got it.
Should I check if there's any comments online?
So I have recommend any homogeneous edible dosage form, including chocolate, chews, etc., be added to the list of edible dosage forms for oral administration.
Yeah, that's, I'm not sure any of these questions have accepted shit, but. All
The
right,
only,
Individual pieces, or no?
and the only other,
I'm missing Jimmy online.
the only other question I have is, would it be considered sublingual rather than oral? That's something I've never really,
Is oral, though, they don't.
Yeah, I think oral would cover that.
Yeah.
Okay,
So,
Well, they're still comfortable.
yes, oral is safer, it's broader, yeah.
Yeah, I think statutorily, it's just infused edible. Is the dose, this is just the allowable,
It's essentially
we're
expanded.
expanding
Okay.
infused edibles.
Okay.
Got it.
Okay,
Okay, that's the,
I-
go ahead, Trevor.
Oh, I'm sorry. I should have mentioned this. I was just looking because we hadn't heard from our other two board members
Oh,
online.
One of them had a comment online?
No, I can't see, Jimmy's not on here, so I wonder if he hopped off, but also Frank has had his hand up and I don't think we caught it.
That was new.
Or is that new? I just wanted to mention that, but you can make your motion. I just thought we might have skipped over him for public comment.
You can see them on there.
I mean,
That was a new reference.
Just now? Okay, I just want to double check.
Frank has something in addition to what his business partners already shared. I think we've made the motion, but could Jimmy just drop off the meeting completely?
I just texted him. We'll see. Oh, yeah, he had to leave at 3:30.
Oh.
But still on.
So Ken is still on.
Yeah, so we still have-
Okay, we just, that was going to be my biggest concern.
Yeah.
Can we actually take action?
We got Kent.
We can't set up there, so we.
Yeah, there we go. Yeah, leave Kent up there. We want to see him in his home office. Right on, right on. Okay, that is the motion. If anyone needs it read back, we can. If not, do we have a second for the motion?
I'll second it.
Okay, we have a motion and a second. Please take the roll call vote.
Yes. Ken Anderson,
Yes.
Nana Garrett, yes. Desiree Hennessy, yes. Chris Morgan,
Yes.
Matthew Page,
Yes.
and Misty Smith.
yes,
JD,
Oh, and
you already know what mine is.
Casey Lorenzen.
Yes. All right, the motion passes unanimously, and that'll turn us to our last item on the agenda. We do have about 35 minutes left, so this one may be a little bit shorter, but I think because we discussed this last time, hopefully this will move a little quicker. So item number 7 on the agenda is regarding telehealth renewals for medical cannabis recommendations. last time when we discussed this, we did have just some discussions around EPA. Trevor's gonna clear some of that up. I do think there's some good discussion to have around what's already allowed in state law when it comes to telehealth. And then, obviously, more discussion after that. So with that, Trevor, please take it away on, the presentation for item number 7.
Thank you, Chair. I know we're running behind, so I will keep this as brief as I can. Let's get started. Let's just go for it, Abby. Quick background, the basis for this proposal is there's a perception that requiring the in-person visit for medical cannabis renewals with a different provider from the original is overly burdensome, could be more expensive for some patients in the program, maybe losing patients because of this requirement. So as of now, statute requires that all initial medical cannabis recommendations be done in person, barring certain circumstances like hospice care, nursing facilities, et cetera. And renewal visits with the same provider who did the initial recommendation can be conducted via telehealth. And if a patient renews their medical cannabis card with a different provider from that original, then it must be conducted in person, again, barring certain circumstances. So I just got these in this morning. These are not in the memo, but just so we can shape the problem better. How many first-time renewals happened with a different medical provider? In 2023, we had 52% of patients who completed their first renewal with the same provider who did the initial recommendation, and 48% completed their initial renewal with a different provider. So to clarify, we went a little bit into federal telehealth prescription laws last time, and to summarize, first off, there is a rule from the DEA and HHS, Health and Human Services, federal level. And they made temporary rules which have been pre-expanded and continuously added on since COVID started, which authorized practitioners to prescribe Schedule 2 through 5 controlled medications via audio, video, telemedicine encounters. So this is an exception to a federal law that has been in place since 2008. That federal law allows DEA and HHS to make exceptions. They did for COVID. They've continued this, and this law has been continued. And its sunset date is the end of this year. Let's do the next slide, please. So DEA proposed another rule in February of last year that would allow for all medical practitioners to prescribe medication via telehealth if they've received a referral from another provider. JD mentioned this at our previous meeting with a chart that shows the flow of how it would work, but that chart was part of a media release for this proposed rule, meaning that it's only proposed rule, it's not in effect. And the board may also want to consider, as we've been talking about previously in this meeting, potential rescheduling of cannabis to a Schedule 3. If that does come into effect, there will be federal laws that govern the prescriptions of that as a specific controlled substance under Schedule 3. But nonetheless, I just want to clarify that what we were speaking about last meeting, that is still a proposed rule, but the current law of the land is a temporary rule allowing Schedule, I think 3 through 5, I said, or 2 through 5 medications via telehealth right now. But that will most likely lapse in 2024, and either this new rule from DEA will take effect, or the Ryan Height Act, which puts those restrictions back in place, will come into effect. Arguments for allowing patients to renew their card via telehealth with a different provider. Number one, I heard that in-person regulations feel like an unnecessary barrier for some patients. This could be patients just wanting to switch providers for whatever reason. They've moved, they're rural, they would like to have a reduced cost to their renewal visit, many reasons. Number two, due to the in-person visit requirement, the medical cannabis program may be losing patients who otherwise benefit from legal medical cannabis use. Number three, telehealth is a common practice. Utah law appears to treat medical cannabis like other controlled substances and prescriptions. And a question is, should cannabis be exempted from the prescriptions of traditional medications if the law appears to treat it like a conventional medication in some manner? Arguments against. Number one, in-person examinations better ensure an accurate assessment. Often a provider seeing a new patient for the first time won't have access to their medical records. They can't secure a release, or they just don't want to trust the other clinic and do their own due diligence with that patient. They can conduct everything they need to in person, take those vitals, run tests, etc. Number two, cannabis contains psychoactive substances. It is not a conventional treatment, a conventional medication. And therefore it seems to some that it would be common sense to require that someone that's seeing a new practitioner or a new medical provider would see that person, see that potential patient in person, given the unique nature of cannabis as a medication. Number three, telehealth renewals are already allowed after initial in-person appointment with the same provider. As we saw, slightly over half of patients who initially renewed this year kept it with that initial provider, which probably means most of those were conducted via telehealth. So there is already an exemption for the slight majority of patients in the law to access telehealth for their renewal. And with that, here are the two recommendations. Allow patients to renew their card with a different provider from their own through telehealth. I guess maybe a 1A to this could be with a referral from an existing practitioner. Or two, continue to require that those initial visits with a new provider for a renewal be in person. And with that, I'll turn it over and happy to answer any questions.
One thing I do want to add is there's already the ability in the law for QMPs to provide initial recommendations via telehealth. Obviously, it's only in certain circumstances involving certain patients. It does talk about hospice, terminal illness, but also someone that's a resident of assisted, living facility. One could make an argument that a resident of assisted living facility might be in more poor health, and you may want to, as a QMP, have the ability to see them in person, maybe more than you want to see, a 35-year-old, healthy, adult. We all would already provide for an exception that is outside of what federal law would currently, allow for. And I said it at the last meeting, I'll say it again, we're already way outside of federal law, everybody, right? I mean, with medical cannabis and cannabis in general, right? And, that doesn't seem to have stopped. Cannabis programs should continue to grow, the legalization just continues. So I think that's one important point. I don't know if you put that in the presentation, but I think that I would just make sure to mention, we already have found an exception, that says for an initial recommendation, you've never even seen this person, you've never even talked to this person. And particularly in the case of some of these people who are very, very ill, I understand, terminal, hospice, different. We're thinking end of life, so maybe not as much of a reason and or their inability to get there. Assisted living, maybe that's part of their ability to travel. But if we've made an exception already for, for those types of patients, it shows that the exceptions, to this could be, warranted. So I did want to put that in. And also too, we do believe in speaking with people, especially now with QMP, it's a lot more fluid, right? Rich, how many QMPs do we currently have? Do you know?
970.
Yeah. So there's a number of them, and I know patients are choosing to diversify, for a number of reasons, right? And I would just hate to see patients leaving the program, especially patients living in rural areas or patients that don't have the ability to just easily travel to see the new QMP of their choosing to leave the program, because I do not believe they will leave the program and no longer consume cannabis. They will do one of two things. They will drive to a state where it is legal for adult use, purchase it there and bring it back to Utah, or they will purchase it in the illicit market. So one way or another, you're either feeding the economy of another state, or you're feeding the illicit market that, legal cannabis is trying to combat it. And so I don't think those patients will just say, oh, I couldn't see my QMP, I'm gonna stop using the medicine that's been working for me, and then I went to trouble, to get a card. So from my perspective, I think that is something that's, both of us fair mention. So with that, I'll open it up to the rest of the board, and then it looks like we only have one, slated for public comment in the room. Don't know if we'll have any online.
I think carrying over from the last meeting when this was discussed, one of the issues was that the medical records don't always transfer with the patient immediately. And I think you could almost have a third option where it would be allowed, so long as the medical records were reviewed in advance by the new provider. So I don't know exactly how we would word that, but I'd feel more comfortable allowing it, assuming the records or whatever the.
So essentially, we just say we would put some sort of restriction on the ability to do a telehealth renewal, and I think it should be a may and not a shall, right? I think if the doctor does not feel comfortable, you know, not seeing someone in person, just like ever, even with the 1-year renewals, right? It still allows the provider to provide less than, you know, 1-year renewal. But I think you could probably just put some sort of limitation around it to say, you know, basically, so long as, there's a qualifier that says, so long as you've met these criteria, then you have the ability to choose to see a new patient renewing their card via telehealth. And I think also, one of the things we talked about is one of the concerns, I think, initially around this was the doc in the box, right? They were worried about someone in say, Oklahoma, we can just choose that state. You know, a doctor there who doesn't have a physical presence here in Utah, who doesn't do initial recommendations, and all they do is telehealth renewals. Well, you could put a couple guardrails around it to say you have to have a physical office here in Utah, and you also have to do, you know, initial recommendations. You have to make them be a true RMP. And so they can't be someone that's outside of the state of Utah. And I think when I talk with people, that seems to make sense, because I don't think anyone here would be in favor of, you know, having our patients be seen by out-of-state doctors with no clinic, you know, here, because you then have the ability to go see them if needed. And your doctor could say to you, you know, hey, I renewed you telehealth last time. This time I don't feel comfortable doing that. It still gives the doctor the ability to practice medicine. It just, to me, removes another barrier that sees patients leave. We've seen over 40,000 patients leave this program. And I don't ascribe to the theory that those people either, one, determined medical cannabis was not for them, or two, that whatever ailed them has been cured, because most people are using this for chronic, you know, or long-term conditions. I'll give you some of those, absolutely, and I hope that's the case for some. I hope cannabis has been so effective that they don't have the symptoms they have. If it's not true for them, I hope they're not using it and having, you know, adverse, you know, consequences or anything. But I just don't believe all 40,000 plus people that have left this program have done so, you know, because of that. Anecdotally, we heard from folks that this, you know, and other steps, you know, with the RMPs can be a part, you know, of that. And I think this is just removing the barrier. And I think, Misty, the way you bring it up is a very responsible way to do it. So.
Speaking of community,
Absolutely.
The only way I could go along with using telehealth with renewals is exactly the way Misty said. As a QMP, nothing is more frustrating than getting new medical cannabis patient coming to me to renew a card from having seen a previous provider, a QMP. And knowing nothing about them, they show up without any medical records. They say they got this condition, that condition. And, you know, I still have, there's still liability on my part. You know, I have to do my due diligence to make sure they truly do have this qualifying medical condition. The only way to know that is to get some kind of a referral or medical records from that treating provider, so I can see what medications they're on. The recent vital signs. I mean, you cannot, as a QMP, know whether or not that patient has uncontrolled hypertension unless you put a stethoscope and blood pressure cuff on them, check that blood pressure level. You can't do that for telehealth. Without a referral, without seeing some vital signs on paper from another provider, you can't make that assessment that this is going to be a safe treatment for them. Ultimately, our job is to make sure that the patient is appropriate for this. This is going to be safe. You know, there's no history, whether it be medical or psychiatric, that is going to put them at higher risk for complications for using this. So we need to be treating medical cannabis just like any other medication, whether it's Schedule 1 or Schedule 3. It's not a benign substance here. Okay, there is still risk with medical cannabis, and we need to be protecting our patients as QMPs and making sure that them receiving this whether it be an initial recommendation or renewal, that this is appropriate. I'm not kidding you when I tell you I've had patients come to me from a CBD shop, fly by night, QMP. Having recently had a stroke after the first 3-month card being given to them, only to find out that the patient has told me they've had severe hypertension all their life, never been treated, but they ended up getting a card. And guess what? They're walking into my office with left-sided weakness and a cane that's for the stroke just a month prior. I could not renew them, and I told them why. Renewing via telehealth has to have some guardrails. This can't be done just in the interest of running a recommendation mill. So that I agree with you 100%. There's got to be some stuff there to ensure that there's proper transfer of care, just like any other patient.
Well, I think that's why the DEA's proposed rule is going to allow it under a referral, right? Which would suggest that there's going to be some form of communication or some record to you as the new QP, right, or as the new prescribed doctor, because either you see them in person and get that information on your own, or it's provided to you by the prior provider. Right. If the prior provider has the ability to provide the information, you would get in person, or at least whatever, the majority of the information in person, or some of it, then you may feel more comfortable allowing telehealth in that.
Of course, and even then, depending on what is in those records, I may still want to do assessment. If those records are 2 years old, it's not recent enough, in my opinion.
I think that's why we follow May and not shall. Make it a May.
So it should be a discretion of the provider, but there at least needs to be a minimum requirement in terms of what constitutes referral and what's standard in those records.
And the DEA's, I mean, its proposed rule just uses the word referral, right? So I would imagine that's the general, concept of what referral is in medicine. We could go there, but I don't disagree with you on the, there does need to be generally within the accepted course of medicine. And that's why I am talking about proposing a lot of these guardrails, and I think we did last time. So
Many times it is the patient's responsibility to transfer the records, not necessarily the physician's office. So they may offer the referral, but not forward the medical records unless the patient specifically requests them to do that.
And we're not required to issue a recommendation on that first visit. If there's stuff missing that I want to see,
Yeah.
I will have the patient reach out to their provider and have the facts, some information that I need. I won't give them a recommendation just willy-nilly.
Right.
I need to make sure it's going to be safe. That's how I do it. I know a lot of patients expect a recommendation at that first visit, but only if it's appropriate.
Yep. All right, any more comments from the board? We'll turn it over to the public for public comment. Anybody with their hand up online? All right, well, then Tim Pickett, floor is yours, my friend.
Thank you again, Tim Pickett, with kindly of me. So I really agree with Chris Morgan here. We take Selectel, we take Medicare, we take Medicaid. Cannabis is not a first-line treatment for any condition, period. It is not. It's a Schedule I drug. Even if it's a Schedule III drug, it still will not be a first-line treatment for any condition. We want the quality and the standard of care to be like any other medication. If I get a referral or a telemedicine consultation, I may recommend or prescribe that medication for 30 or 60 days before I see that patient again. JD brought up the example of a telemedicine that is allowed in somebody who's in a facility. In those cases, you have access to the medical records. You're getting a direct referral from another provider. You're doing a lot of due diligence before you're recommending medical cannabis to a patient like that in general practice. So we already cannot do a telemedicine renewal within our own practice due to patient caps, which is something that we have tried to adjust the statute on for year after year. And this goes just too far, in our opinion, to just say that there's gonna be a QMP in New Jersey who renews everybody in Utah for, $25, and that's the definition of recreational. And recently, I believe it's the Washington Post just wrote an article about psychosis increasing in 18 to 25-year-olds because of high dose THC use. And this is a good example of that. We would be increasing that risk really dramatically with this policy. So we would oppose this as something that the board would recommend.
Let me ask you a question or two, even with the guardrails we propose? Even with the guardrails that the QMP on the board's talking about proposing, still would be against it?
Yes, because the burden of getting those records is something that somebody will gain. I can almost guarantee you can't create a system that will sufficiently get me the records to do a telemedicine referral. Chris won't see a patient to do a 1-year prescription for any medication on a telemedicine referral without doing a huge substantial amount of due diligence on that patient. And what you're asking for is scalability to do this at scale, so that 48% of the renewals now have another option. A one-off, sure. One patient, sure, I could make the argument, but you already have that. Those patients are in the home or terminal. I don't see this as a solution. I think within a practice group, if I could take the records I already have access to within my own practice group and renew the patient, because my partner is on maternity leave for 6 months, which I can't, by the way. I cannot do that via telemedicine now. I could do that because I have access to their notes and I could call them. But that's the standard of care that we're talking about. We just don't get that. And we're trying to legitimize medical cannabis. We're trying to make it like medicine, right? Like, it's like Tylenol in your cupboard. There's an algorithm, there's a process, there's a procedure to get medical cannabis. What we're doing, what I see, and what the QMPs that are in my practice see with this is recreationalizing medical cannabis. This is Californiaizing medical cannabis. I go on vacation, I call the doc, I get a recommendation, $55, I go to the pharmacy. That's not medicine.
But just like we talked about with the chocolates, isn't our job to find out what works for the patients and not be trying to stick up guardrails for people that might be wanting to look at this as a recreational program? But are we supposed to be, I feel like it's our job to be looking at what do patients need. And there are groups of patients that truly do need this as an option. So whether or not it makes us feel icky, or it's not the way that we received the program to go, if we have patients that are left on the fringe and we're not helping them, like, that's what we're here for.
But you and this board has no liability for that decision. I and Chris, we have the liability for that decision. For the stroke patient who comes into his office, for the 20-year-old psychotic patient that now is institutionalized because they were taking high-dose SSRIs and high-dose THC, that's my liability. And that's my ability to treat those patients later. I need a good assessment. So what I'm saying is we need to protect those patients as much as we need to give them access. So if I can get Medicaid and Medicare and Select Health United to cover this type of process, that's legitimizing and decreasing the cost of the patient. And I can live within the scheduled guidelines of a scheduled medication. What I'm saying is that going outside of that system is what you're asking me to do. And that's.
You don't have to. I think we were clear that like it's a may. So, but I see what you're saying. What I'm just processing, because this isn't, favorite thing either. But the people that are going, the QMPs that are going to manage this well and care about their patients are going to do it online or in person. If they are on telehealth, I assume, and they're a good player, they're gonna say, "Can you come into the office? I want to check a couple things. Can you send me more information? Could your family member, you know,
But
could I
can
do a
you
health call?"
guarantee, Desiree, can you guarantee that I'm not gonna go from 4 to 7:30 to Sheets Brewing and pay $75 to do a telemedicine?
I can't guarantee anybody isn't gonna do anything wrong.
Because that's what the legitimate side deals with on the other side.
Yeah. Oh, I know, I see it all, but I also feel like we're spending a lot of times always trying to protect the people from playing badly and not paying attention to the patient's needs. So I'm just trying to remind everybody that there's also patients that need this, and there will always be patients or people that are predatory.
I think to say that you're trying to legitimize the medicine as if someone else isn't, I think is a little disingenuous as well. We're all in this for medical cannabis. This is not being put forth because we see this as some new card mill technique to try to get more patients in the program. The fact is, patients are leaving the program. We believe this to be one of the reasons that they are, and we're willing to offer guidelines around it. And it's something you could do or choose not to. If you can pick it and kindly MD don't feel comfortable, I think that's just fine. So I just want to make sure to reiterate, we're not saying, Tim, just let me finish and then we'll recognize you again as a member of the public. We are not trying to do anything other than try to find other avenues to allow patients who want medical cannabis to continue to obtain it legally and not find reasons for them to go back to an illicit market or to go and feed the economy of another state, right? So let's be clear that you have your opinions, but I hate to come and paint with this super broad brush that we're trying to turn this into a recreational market or anything. You've heard here today 4 or 5 guardrails that have been put forth by this board and members. Our new QMP has talked about who may be comfortable with it, right? That's why I think we say may if we do. It's not a shall, we don't require you to. I think what we're just trying to do is look for reasons to keep patients in the program. Just like I know you've looked for it. Isn't that part of why you push for insurance? Right? Isn't that why you're pushing to allow your doctors in your own office to be able to refer to one another or for them to see a patient in place of you? Well, you took vacation, right? So I just think we need to be a little bit careful, you know, in painting with a super broad brush in that regard. So with that, oh yeah.
Well, I do have a question. I mean, Rich, do we have data on the patients that have chosen not to renew their card? Is it because, I mean, do we know what that percentage is? I mean, comments were made that, you know, a large portion of it is potentially due to QMP not renewing or availability. I mean, what is?
Ongoing, it's about 40%, but we expect the 1-year renewal will make that 40% go lower.
We don't know the
40%.
exact reasons, right?
No, you don't know.
Just has never done a survey to
No.
determine why someone doesn't renew.
No, we haven't done a survey.
Is that something that could be done to, I mean, I'm sure you still have their contact data for information. but
Yeah, we
do a
could
survey.
consider it. We're really careful when we
Oh,
send
yeah,
out a
last
survey
time.
that big.
Yeah.
Because obviously it's a giant survey. And we'd be going to people that no longer in the program.
I'm interested
Right.
though is, I mean, are many of these patients who aren't renewing because, you know, they can't find their QMP anymore? QMP was just got up and left and is gone. They hit their cap and they just bailed on everyone.
900.
Another study
I mean, that's,
heard it's 12%. Based on a study that was conducted by by the University of Utah. 12% of them are going out of state for medication, and it's specifically because of cost. They can't maintain an adequate supply because.
Yeah.
I hear a lot of it.
I mean, I understand that, you know, there's a need to allow a renewal. I mean, obviously, I feel like it has to be, say, I broke down 3 safeguards here that has to put it in. I think the concern I see posts all the time about, hey, we're showing up at this pharmacy, come get your cheap card. Great, are they doing it for 1 year? They have no idea who this is. Who knows where that QMP is coming from? They could be coming from southern Utah and they're going to northern Utah to go get all these cards out. They're never gonna see that person again. And are they doing renewals? Because then we're gonna be in the same situation we are today, is they need to find a new and compete, not because they don't want medical cannabis. It's their QMP is there. or they'd rather focus on that. I mean, I think that's, to me, one of the safeguards I threw in there is that, you know, recommending medical provider must be doing initial medical cannabis recommendations. It can't just be a renewal doctor. It doesn't work that way. I mean, you need to have that relationship. And I think that's what, I understand what you're saying is you lose that relationship with the patient and then that standard of care they get diminishes. And that's where the liability between Chris and you as QMPs, you're liable for that. We're not. I mean, the pharmacy at the end of the day, they're just doing what the recommending physician is recommended to get. Most of the time, it's just that checkbox saying, get whatever you want. And they might be buying the maximums and whether that's safe for them. That's whether or not that QMP took the time. I just feel that, you know, there is an issue. If renewals allowing them to provide them with medical paperwork, and although they had a card, it's expiring and they can get to a new QMP via telehealth, and they've already hit in the end, the patient does all that, we shouldn't be saying, I'm sorry, we haven't seen you. And I'm sorry, your QMP is gone. Now you gotta come in and then they don't have access. It just, I hate turning away people when they need a medicine to rely on.
All right, anything more from the,
Am I understanding it correctly, though, that requiring or allowing them, even with the safeguards in place, to go to the telehealth would result in the loss of the Medicaid and Medicare coverage?
You know, we're not gonna do a Medicare or a Medicaid or a select health telemedicine medical cannabis recommendation, because that's not the standard of care for medical cannabis in the system or any other medication for that long. So from a traditional medicine standpoint, if I'm gonna prescribe or recommend a prescription medication for a patient, I'm gonna see that patient over and over.
Yes.
Right? And that's gonna be the medical standard for billing insurance. And whether medical cannabis is part of that plan, in this case, because the recommendation carries with it. And I know that I'm gonna get a comment about, I can choose how long I can give the recommendation. But the de facto demand from the patient is a year.
Okay.
Right? So we have to deal with the patient.
Yeah.
And the patient is gonna demand
Yeah.
a year
Yeah.
for the cost.
Yeah.
Right, and so they're gonna just search out a few people.
Yeah, I understand.
So we won't be able to do that under insurance.
I wanted to mention that point is in the memo. It says that if this becomes the law, then a recommending medical provider that requests to meet someone in person, a prospective patient may not want to see that provider and go to a virtual one because it's easier for them, right? Whether that's for, you know, a good reason or a bad reason, it will make people easier to say, well, why would I go see you? If someone's primary care physician is also their QMP says, you know, as your PCP, I want to see you in person every time to make sure we can go on this journey together. I'm monitoring your vitals, et cetera. Those patients may decide to leave for a telehealth renewal, just a consideration.
They leave now for things like cost stuff, you know. I was gonna say, why are they?
Yeah,
It's
they're
usually money.
they are leaving for cost. And again, back to the insurance, I know I'm hammering this, is that ties the patient to the provider and allows us to have a relationship beyond just the cannabis. The safety issue increases as the relationship increases. So the more relationship we can have with these patients, the more we keep them in the program, we keep them using safe medications, we follow up with them. So I was opposed to the 1 year, you know, as opposed to getting rid of the 3 month because we don't have that follow-up. And so everything we can do to keep the patient seeing us regularly in continuity of care helps the safety and the outcome of the patient. And
Because any other Schedule 1 or 2
any
or
other
3,
medication, period, you know, period, we're following up with that patient much more frequently than this would say.
Yeah, the memo also mentions in arguments against point 2 that medical clinics routinely require new and returning patients to come in person for Schedule 2 and 3 prescription refills, such as every 30 or 90 days. So just a consideration that if, you know, and I'm not sure how many QMPs do 6 month versus 1 year, but either of those seems to be much more lax than other Schedule 2 and 3s. And some of that is just the clinic's practice. Some of that is also federal law.
Just another thought here is that the state law does require that prior to any initial or renewal appointment or approval, that the controlled substance database be checked by the QMP to review anything concerning that they see in a pattern of prescription and FDA-approved controlled substance drugs. And it's difficult to audit that, but that is the state law. Also, the EBS is a resource that the state has created for QMPs to be able to use to share information that would be accessible to a new medical provider. And so that would be one way to meet the current, or what was proposed as sharing records. So if the QMP would feel comfortable sharing in the EBS, some don't, but if they did feel comfortable doing that, they could share it within the EBS and meet that amendment if that were approved. And also the EBS could be modified to be able to capture a referral. If it were recommended that come through the board, that would be one way to make that referral, to document it, would be in the EBS, and for us to be able to audit it to make sure a referral actually happened. Be difficult for us to do it if it was done outside of the EBS.
Would it be a fourth option then, that the electronic renewal could be done with a different provider electronically if it was a 90-day renewal versus a 1-year renewal? If it's the duration between physician evaluation that's an issue?
I don't know, Chris, when you see a telemedicine referral, do you prescribe medications for longer than 30 or 60 days?
So before Chris answers, I mean, I wasn't able to step away from the table, he's not a member of the board. So I appreciate his comments, but we had enough of that, so we'll turn it back over to Chris.
Regarding any kind of telemedicine visit, if it's not a patient, it's an initial telemedicine, it really depends on the medication. If I consider the a high risk diabetic, I see a lot of diabetic meds for patients. It's about 80% of my practice. If they need insulin, yes, I will prescribe anything that's that I deem an emergency need, and see them on a telemedicine basis to ensure that they're safe in terms of staying in that medication, provided they follow up with me in person in a relatively reasonable time, usually within a month. In a situation like this, I do not consider medical cannabis an emergency medication or emergency drug of any kind. So this is something that you know, if I was to do a telehealth visit for a renewal, provided proper referral, and I felt comfortable with the information I received from the referring provider, to go ahead and make that recommendation. It really depends on the patient, their health status. You know, they got a lot of comorbid conditions, or they just have a chronic pain, back issue. I don't know. I may give them a 3-month renewal, I may give them 6 months. If I look back past their history, they've had a car for 3 or 4 years, and they're stable, and they have relatively low risk. Yes, I might give them 1 year. It really depends. And so that really needs to be on the discretion of the QMP, because ultimately they're responsible for the safety and health of that patient. But in terms of this particular agenda item, you know, I can support it with some certain stipulations and conditions.
There to eliminate, illustrate what those conditions would be.
Sure. Do we make a motion? Or,
Well, you want to make the motion, go ahead, sir.
okay. So I motion to approve telehealth renewals for medical cannabis card patients, provided Three criteria. One, a referral is received from the previous provider. That referral, two, the referral includes recent medical records to substantiate the qualifying condition. To include, of course, vital signs. Current medication is, the standard referrals. So, recent medical records. And that the patient has seen a QMP in person within the last year. You can't go more than a year without a patient being assessed by. Does that make sense?
I've seen a QMP or seen a
Oh, I'm
doctor.
sorry, I take that back. That has seen their provider, their treating provider within the past year.
So
Assuming they have, yes.
I think the only other thing we would probably want to, caveat is just making sure that this is seen in, an RFP that they have not seen previously.
Correct. If they're switching QMPs.
I would recommend defining recent, because recent can be a lot of things.
In my practice, I consider recent 6 months or less.
Okay.
That's the criteria these are on all my patients.
I think that's fair.
So they have to have been seen by their primary care physician, assuming they have one within the last 6 months.
Primary care physician or the treating physician, pain management.
Something like that. So if they have not seen that primary, assume they don't have a primary care, they don't have a treating physician, if they met those other two criteria of the referral and had a chance to review medical records, would that be sufficient?
I could accept that, yes.
Can I make a clarification by treatment provider? You don't mean, do you mean the recommending medical provider that did the previous medical cannabis recommendation?
Well, it depends on who that provider is, it should be the person treating the qualifying condition. I guarantee you, there's a lot of QMPs out there that do not have medical records on these patients and cannot provide those referrals.
Well, I do know some doctors who don't prescribe medical cannabis,
Mhm.
but they do have maybe a relationship with QMPs, and they'll send their patients to them to get them, but they still.
Correct. I have referral agreements with the pain management clinics in Logan. I get referrals from them all the time, as well as other local providers, rheumatologists.
So like a bona fide relationship with the
There needs to
patient?
be an existing patient-provider relationship with a treating medical provider. Yes.
And that could be a QMP or it could not
It
be.
can be a QMP, it could not be a QMP, as long as they're treating a qualifying condition.
Right.
With the caveat that they don't have. Yes, they would have.
If they don't have either of those, then obviously you would need to do an in-person visit.
You would still have the discretion
Absolutely.
to always see them in person. You don't have, this is not a shall, this is just a maybe this.
Exactly.
Do we want to condition anything on having an actual location in Utah?
Does that concern you at all, the document box? Like, I said, it's a brick and mortar here.
Oh,
And I also have to do additional recommendations.
I don't know, maybe I'm ignorant, I don't know how many are getting these from out-of-state providers, that just have to be licensed.
Doesn't the other one just say they have to be insured in Utah? Isn't that
Insured is a
license, the license
That's a
and
license
insurance,
you
yeah.
talk
Well,
provider.
oh, yeah, that already is the law.
Yeah, so I was just saying, would that be a better thing to add? Than
Yeah,
like, they have to have
So just a licensed Utah provider also does initial recommendations.
And that's already in the law.
Yeah, so I'm not sure we need to add that.
Right.
Yeah.
Okay.
But the physical location, that was a concern that was expressed earlier. Doing it on the couch and vapor dreams. That's what happens.
that sounds like a good.
But even in a physical location here, they don't have to necessarily do recommendation at their physical location, right? So I mean, they can do, that can happen on, if they want to do it in a doctor's office or, at another location.
Right, and I think it's a subject for a separate,
I think the physical
Discussion
location is
about-
just making sure they weren't an out-of-state doc,
sure,
just doing it from, Minnesota,
right,
and not having the ability to ever see a patient in person.
right. So is the interest then like having a street address that's the brick and mortar spot where if it were in person, you would meet with them? What is your brick and mortar location? QMP.
Yeah, but to me, I think if it really is already, they have to be licensed in Utah,
Yeah,
I think that should, if that's what's already in the law, I think we can probably just stick with it.
yeah, but we do know that we have QMPs that live outside of Utah who do recommend telehealth, and they have probably never been to Utah. And they do a telehealth. And that's how they roll. And it's national companies that are the clinic, right?
No, we're definitely.
Yes, all that.
We get the sub comments back to when you read the motion.
Yeah, I got a lot of information about it there, so.
Before the motion, is there any more public comment?
Oh, we forgot.
Sorry.
We had one more public comment.
All right, just real quick, I'll reiterate. Well, just from what I'm hearing, just if there maybe to solve both ends is right now, you can only do renewal. We see patients that are stored within 30 days is when their renewal window opens. If you extended that renewal window and then to 60 or 90, then that gives the new telehealth person enough time to review the stuff. Stuff meaning medical documents, sorry. Just generalizing here. So then you have some buffer where you're not going to risk somebody doing the bait and switch where they just got a recommendation for a car drive renewal, whatever. It's putting teeth in it where it's saying if you're going to switch, you have to do it, extend the period, but then force the QMP to upload those notes and do the things that Chris was mentioning, because 30 days, what I experience at the retail level is we'll see a patient come in and we'll let them know, hey, your card is expiring within 30 days. A lot of the times they don't know who their QMP is because of this going here and finding the best price. So I have communicated those concerns with DHHS, and some of the recommendations were printing your QMP's name on the back of your card. So I think that would be a good reminder for the patient to know this was my doctor. I'm going to go back to them. So those are some things that aren't relevant here, but I think are in motion that could help kind of close that loop. But maybe extending that renewal window if they are going to do a switch to greater than 30 days. And then that could, not force, but allow the QMP to do that review.
Well, just to make a note though, patients have access to EBS. The EBS does have to provide the QMP's name information.
Understood, and everybody to get their card, everybody who would get their card had to go through EBS. But as we've been doing some of these card drives, I've also noticed a lot of people don't know their EBS. Like they
forget their
I'm talking about the login.
Yeah.
Right, so for them immediately to know who their QMP is, it could require multiple steps for them to reset their password going there. So I think having it on their card, yes, everybody should be able to access it, but I think printing that would be a low hanging fruit for DHHS and patients.
And the law doesn't need to change to do that. We can do that.
No, and I believe Sarah Liebo sent an email.
Yeah.
To some people asking what other fields would be valuable.
Yep.
I think QMP, caretaker, and your caretaker patients, in case you ever forget who you're a caretaker of. But just providing the perspective, I don't know if that 60-day window provides the buffer, because I hear the concerns of Kindly and I hear the concerns of Chris and other board members. So I think that could be a happy medium.
And I believe the 60-day, that doesn't require statute change either. No, that's like a internal, like we open it up in the software.
30 days before,
Right.
You just send it 90 days. not
Right.
30 days.
Right.
Because I don't believe that a patient can initiate the renewal visit until they get that.
Yes.
thing
Yeah.
back.
That's right. And our software says that.
Okay,
It's not in statute.
so we could make that adjustment
In
in terms of 45 or 60 or 90.
Yeah, we can talk more about it.
Okay.
But it's a good, glad you caught that. That is a factor.
And the other thing too, again, just not the QMP world, but is there anything where to prevent just the renewal mills and to also honor the care that other QMPs are doing? Is there a balance of new versus renewals that we need to look at QMPs to say you're not just a renewal mill? You need to have X number of initial visits. So there is some equilibrium on the QMP side. So they're not just some guy in Oregon spinning up a lease here and then renewing 90% of the patients here. So maybe having a balance of new versus renewal. So there is some teeth there. And I also do think in some situations, personally, diagnosed with ulcerative colitis for 18 years, cannabis is an emergency medication. rather than taking prednisone, my GI would recommend prednisone. So just from personal experience in my eyes, I would view cannabis as an emergency medicine as, aside from prednisone, that's my only option to mitigate the flare scenario. So I don't want to generalize it and say it's not an emergency medication, but just sharing my.
Thanks, John. All right, back to the maker of the
The
motion.
motion. Hey, take
Abby,
my,
you wanna read it back and then we'll see if you need to clarify anything?
Yes.
Or do you want to make a new?
No, she doesn't do it.
Oh, okay, right. Yeah.
Okay, so we have, QMPs, they need to telehealth renewals for medical cannabis cards, provided the following conditions are met. First, receival of a referral from a previous medical provider who is treating the patient's qualifying condition. Second, receival of recent medical records from the patient documented 6 months or less of meeting with the QMP. Third, that the patient has seen a provider in person within the last year. And fourth, that the recommending QMP has a physical practice in Utah.
Then the only other going thing was just making sure we clarify that they can see this is saying new, because currently you can already do a telehealth. We don't see that with your current provider, if you're switching, this is when you switch providers. Just make sure
Say like QMPs may do a telehealth renewal for
patients, yeah, for patients. I mean, the statute has the language, it says exactly what it is, so we can probably just, when you do the
We
recommendation.
can, yeah, we can dress it up how it needs to be in the law. Sure.
Okay, we have a motion, which I'm not going to repeat, as well as a second. Abby, will you take the roll call, please?
Yes, Nancy Anderson,
Yes.
Nana Erezi, yes. Desiree Hennessy,
yes,
Davey Lorenzen,
Yes.
Chris Morgan,
Yes.
Matthew Page,
Yes.
and Missy Smith.
yes.
Okay, well, that is the final order of business. I don't know if we have time to go over the next meeting's agenda. We will be meeting, it's later this week, right? Which day?
Yes,
Thursday?
Thursday.
Yeah, so we'll be meeting on Thursday, to go over some strategy. Did you put it on, is that on our calendar?
It should.
That we sent it.
I may or may not be able to attend that meeting.
So we can
Yeah,
reschedule.
we
Yeah,
know.
or you guys are welcome to meet without me instead of trying to concern. But, if we're able to reschedule, that would be wonderful. Just have a problem with that this time around. But please, for those of you, other members of the board, please submit topics you would like to see the board address. I know Jimmy's not on, but I know I've been asking Jimmy to submit the thing he told me about many months ago.
Was it the, what,
It's law enforcement and the penalties they face for.
we bypassed that, we fixed it, the chair.
Okay, I don't have to do that, but I'm just saying in general, please bring those things, forward. I do encourage all of you to attend the legislative session, as you can. But please also, let's try to be as flexible as we can during January and February. If we do need to move meetings around and or hold, additional meetings, this is probably the only time of year where we will. With that, I will take the most popular motion of the day.
Move to adjourn.
He's not available, I imagine he's
Well, we-
accepting.
that's quick on our calendar, so.
No,
Okay, thank
We
you.
got some
Okay.
chairs to figure out what's next agenda.